Taylor, I'm ready for you.
Oh.
So you. I'm gonna go.
That's what it texted me.
Yeah, it's looking great.
They don't have to.
Yes, that's a great idea. So who's your first speaker? Okay, let's just ask him to sit there. We'll direct you. No. Okay.
Sure.
Yeah.
I'm sorry, son. It's just that, I don't know. You say.
Good morning.
Morning.
I'm so glad that you're all here. I'm Ann Garst Taylor and I'm with AIM at Melanoma. I'm their Director of Community Engagement. And I'm going to get the opportunity later on to tell you a little bit more about AIM for those who don't know our foundation. But I'm up here for two reasons. One is to thank Seidman Cancer Center for co-hosting this symposium today. AIM co-hosts symposiums all throughout the year with cancer centers. And we're so grateful to Seidman. This is something we've been looking forward to for some time now. Dr. Mangel and I have been planning. And we're so grateful to them for helping us to disseminate information to the public about research and treatment in melanoma. And I know that there will be a lot of questions today, both from the room and from those of us who are joining us live via Zoom and Facebook and YouTube. So that's my second job, is to explain how you're going to get your questions to our panelists today. If you're with us in the room, then you were given a packet. And inside that packet is a chat. You can write your questions down for our panelists. And this is Taylor, our volunteer who's turned into our AV specialist this morning. She is going to gather, if you'll just, when you write down your questions, if you'll just hold them up like this, she'll come collect them and then bring them over to Dr. Mangel so he can disseminate them to the correct panelists. And then if you are joining us live, if you're joining us via Zoom, if you look at the bottom of your screen, you'll see a tab, and that tab says Q&A. We'd like for you to put your questions in there. And if you are joining us via Zoom or, Facebook or YouTube, then you can just put your question into the comments field and then we will transfer it over into the Q&A tab. And so with that, it's time for us to start our symposium, and time for me to hand the podium over to Dr. Mangel and let him start our symposium today. And thank you again for joining us.
Good morning, everyone. Thank you so much for driving to Cleveland on a Saturday morning and taking your time out to be with us. This is a symposium we have been planning for quite a while, and as Ms. Taylor told us, we love our patients. We love our community of patients with melanoma. And without any further ado, I'll introduce Dr. Gary Schwartz. He's the director for our Case Comprehensive Cancer Center. He has had an illustrious career. He has been at Memorial Sloan Kettering, Columbia University, and he came over to Cleveland around 2 years ago, and he has had several initiatives in clinical research in cutaneous oncology, especially melanoma. So, Dr. Schwartz, please welcome.
Hey, everybody. Good morning. So as Nick was saying, I'm the Cleveland about 2.5 years now. Spending time at Columbia University Memorial Sloan Kettering Cancer Center. I'm the director of the Case Comprehensive Cancer Center. You know, not familiar with Case. The Comprehensive Cancer Center actually integrates 2 hospital systems of Cleveland, both Cleveland Clinic and University Hospital, as well as Case Western Reserve. So all the science that comes out of the university programs and the 2 hospitals comes through the Cancer Center. as well as any innovations in medical care, medical research. We also work with the clinical leaders at both hospitals to make sure the patients at both UA completed clinic have access to the latest advances in cancer medicine. So my background is in melanoma and sarcoma. I actually continue to treat patients with both diseases, more sarcoma these days than melanoma. In fact, I'm the only oncologist in Cleveland that has privileges at both University Hospital and Cleveland Clinic. So you can see me at other center. It's a novel paradigm with other oncology will one day pick up. But I was there at the very beginning when melanoma was a horrible disease. Still not a good disease for many patients, but there was a time if you had melanoma, an advanced melanoma, it was truly a lethal disease for all patients. So what are the advances that made the difference? Oh,
And then this is a
So
laser
now I
pointer
have-
if you'd like
I
it.
got need education on how to use it. Shouldn't have gone away too soon. Nothing's full. See, it's not me. I always blame myself for these things. Then my kids were up here, they would say, Dad, come on. Work here.
There you go.
Oh, so
I woke it up.
there we go, success. Wait, Saturday morning, everybody's a little sleepy. It's okay, so where did it all begin? I think there are two seminal, I just want to review the historical perspective of how we are, how we got here today, you know. And I think there are two really seminal advances that were developed in the last 15 to 20 years. And the first is the concept of precision medicine. That is, can you take a tumor and take the DNA of the tumor, and can you put it into a machine, sequence it, and find genes that are responsible for cancer growth? Well, 15 or more years ago, this was really just a fantasy, science fiction, some would say. The first actually person to have it done was Steve Jobs from Apple. He had a very rare form of cancer, and he insisted that his DNA be sequenced. At that time, it took 12 months. It was about $1 million to sequence his DNA. Today, we can do this in 7.2 seconds, and it costs about $50. Now, your insurance company will see $2,000 to $3,000 on the bill when you get it done, but it's really very inexpensive today and getting cheaper all the time. So how did that help us? Well, it helps in melanoma, because melanoma is actually not one disease, it's many diseases. And the top here is a more classical melanoma. That is the one that arises from sunburn. And that melanoma is, when we sequence those patients' tumors, they have this mutation in a gene called BRAF. I'm going to talk a little bit about that. And there are also gene mutations in the other ones called KIT and RAS. In the middle three, there are tumors from melanoma that are not sun-related. So you can get melanoma from areas where there's no sun. You think of sunburn as the cause, but actually you can get melanoma from chronic skin damage, a little different, but from areas that are sun exposed. In the middle panel is actually melanoma arising in the mouth, but you also get melanomas in the bottom of your feet and the palms of your hands, under the nail bed. No sun, very little sun. So what makes those different? Well, if you sequence those, they have BRAF, but they really have a major new gene called KIT, 30%, very different than the skin ones. In the very bottom panel, there's a form of melanoma that arises from the uvule, the eye, called ocular melanoma. I'm not going to talk about that today, but that is a gene mutation, not BRAF, not KRAS, not KIT, but something called gene acute gene 11, a very different mutation. So we made major advances in trying, now that we've identified these mutations by sequencing, can we develop drugs or therapies that block them? Because these are oncogenes. They're the engines of the cancer cell. When you have them in the tumor cell, they're not hereditary. These aren't genes you pass on to your kids. They're there from some sort of environmental insult. Now, the most common then is, from the sunburn. Because UV light is actually one of the most potent carcinogens known to man. That's what we talk about sunscreen prevention. I'll talk briefly about that at the very end. But what happened was, maybe 20 years ago, there's a drug developed called vemurafenib. And vemurafenib is a BRAF inhibitor. It blocks that oncogene, that mutation called BRAF. So these are patients that walked into our clinics over 15 years ago. This is actually a patient from MD Anderson, one from Peter McCollum in Australia. Australia's very high incidence of melanoma. They have a lot of sunburn. And what I'm showing you is a PET scan. Now, what is a PET scan? A PET scan is a metabolic study. And so unlike CAT scans, where you look at the size of the tumor, on a PET scan, you see the activity of the cancer, the metabolism, the actual energy. And in this patient here, responded to this as a melanoma. And these are the bones. His bones are literally riddled with melanoma. Here's a man from Houston. That's his liver. It's completely filled with melanoma. Those are metabolically growing active spots in his liver. He has some in his bone as well. These patients walked in, well, no, most, I take it back. They didn't walk in. They came in wheelchairs. They came in on stretchers. Because all of a sudden word got out, we have a drug that blocks BRAF. And everybody wanted the drug. Everybody wanted the drug. And why did they want the drug? Here's what happened. Within 6 weeks, this man's bone metastases, gone. This man's liver metastases, gone. 6 weeks. We could tell in 2, because all of a sudden they walked in. We've never seen this in medical oncology before. We gave it a name, the Lazarus effect, the rising from the dead. Because oncologically in cancer medicine, this has never been seen before. And now we had a pill that would block a gene that makes cancers grow with complete eradication, complete. Okay. Success. Well, we thought we're gonna go out and close shop. Okay. Honestly, I wanted, one day my dream is to put a sign on my door, go on fishing, okay? Because they don't need me anymore. So I'm taking the same patient back, the one on the far, your far left. Here he is, 3 months later, it's back. Okay. So despite our initial enthusiasm, many of these patients, not all of them, develop recurrent disease. And what was going on? So we went back to the machine. We took the tumors, we put them back into the machine. We say, is there something growing, is there something developing, a new mutation that we need to block? Because tumors are smart. They find a way to bypass the block. So this is the blockade. It's a little, it's cartoon, but we know we can block BRAF, okay? But they take like this as a circuit, okay? What's below BRAF? There's another gene called MEK. So they developed a method with a mutation to activate this part of the pathway below. So it was blocked here, but they didn't need this. Now they can activate it here and reactivate the pathway. So we're smart, we're oncologists. We said, let's develop a drug that blocks MEK. And today in oncology, if you're a cancer patient with the BRAF mutation, you get 2 drugs. You get one that blocks BRAF and one that blocks MEK. And this is the reason why. And this has transformed the field. So those failures are now much more sustainable. Now patients still fail, undoubtedly, from this targeted therapy, but the doublet has prevented that rapid recurrence we saw because now we have a dual inhibition. We have the upstream blockade, and now we block the downstream blockade. Now, do other activated steps develop? Yes, and it's still a challenge trying to figure this out, but this is how we got to the concept of 2 drugs, a MEK inhibitor and a RAF inhibitor together. Well, what about those other oncogenes? I mentioned on they're melanomas that come from non-sun exposed parts of the body. And they have a gene activation called KIT, K-I-T. And at the time I was doing melanoma, I'm also doing sarcoma. We have a drug called Gleevec, a manna that blocks KIT. We've been using this for about 2 years. So I said, well, if it works in KIT mutant sarcoma, what about KIT mutant melanoma? Okay, an oncogene, a drug, a blocker. Just one of the first patients treated with Gleevec, and it was a melanoma and no sun. Here it is rising from below the toenail on the big toe that is in PET scan again, the metabolic activity, the left foot. And he had multiple metastases going up the leg because that's how the tumor spread. We put him on a pill, no toxicity, 1 pill a day. He had a mutation in KIT. Within a month, you can see the melanomas are now going away. Within 2 months, they're completely gone. We're so surprised, we biopsied the areas, and what you're seeing here is no active cancer cells. What you see is melanin pigment. So this melanoma comes from a brown pigment. tumor cells were eradicated, but the pigment, which is non-malignant, was left behind, but no cancer. The patient was cured. Again, another example of using genomics, using cancer sequencing, finding a gene, finding a drug, blocking the tumor, and curing the cancer. But you have to do the sequence. That's the key. Now I'm going to shift a little bit to the next seminal discovery. And everybody knows about immunotherapy. Okay, so here we have, what is immunotherapy? So immunotherapy is the activation of the cancer-fighting cell of the body called the T cell. And on the T cell, there are what we call immune breaks. And at the beginning of this field, I was working with a fellow named Jim Allison, who was at Memorial Sloan Kettering Cancer Center. And, I've been an oncologist for over 30 years. And the question to me always was, Dr. Schwartz, why cannot my immune system fight cancer? And before these drugs came into existence, the patient would bring a Bloomingdale, as a New Yorker, bag of pill bottles, throw them on the table, all vitamins and herbs, and say, Dr. Schwartz, which one can turn on my immune system? Well, most of them didn't really have an effect. And the question internally has been, why cannot our bodies fight cancer? Why cannot our immune system turn on against cancer? Well, the reason is, in the evolution of man, and I can't give you a reason why, there are these brakes that put the T cell to sleep. It's like a car. Your brake is on, it's not going to go. Release the brake, car goes, car moves, of course, and can you use the same idea to cure cancer? That's the idea. So we have these immune brakes, they're stop signs. So no, it's a stop signal. That's your foot on the brake. It's not going to do. It's not going to go. Your car's not going to go. But can we develop drugs that release the brake and, in fact, make that green light go on and the T cell to go forward and the T cell to fight cancer? So that's the concept. Okay, that's immune checkpoint therapy. Drugs that release the immune brakes on the T cell to fight cancer. The first one was called CTLA-4. You probably know that drug. It's called Yervoy, ipilimumab. The second one down here is a Keytruda, Opdivo, Vivo, pembrolizumab. Those are drugs that that target the second one. Now, the advantage of the first over the second. The first one, we think of Ipi, which is Yervoy. It's the master brake. It's the brake that activates the T cell, not just to fight cancer, but to go after every cell of the body. And that's a problem because we have toxicity. We know about that. The PD-1 brake is a little more cancer specific, so you avoid some of the toxicities. But at the beginning, all we had was this one. All we had is this one. And remember the first patients we treated. This was a man who had melanoma in the back. We don't usually see this much anymore. Bad melanoma. Those masses are melanoma. He was placed on Yervoy, ipilimumab. And at week 12, it looked like the tumors were getting bigger, not smaller. And in fact, at this point, we thought it was a failure. But this man was having horrendous toxicity. Diarrhea, inflammation of the liver, effects on the adrenal gland. And we're thinking, what are we doing? We're torturing these patients and the tumor's getting bigger. So we said, come back in 4 weeks. And the tumors began to look a little smaller. In fact, you can see this in the CAT scan. Tumor, this is all tumor. Week 16 began to look a little better. By week 72, it was gone. This man tumor never came back. So what was going on? At week 12, the T cells were activated and began to infiltrate the tumor. I should think of like this as Lady Pac-Man. Lady Pac-Man cells infiltrating the cancer, making it look bigger and swelling. We had to biopsy the tumor to see the tumors were going away, but these T cells were eating the cancer apart. And that's what happens with these drugs. It takes a little time for this drug, a little faster for the Keytruda and Opdivo, but this is one of the first episodes. In fact, we were so disappointed early on, we almost gave up. But this one, so what happened was we went from ipilimumab and the toxicity, and then we went to PD-1. It took about 2 to 3 years to discover the second checkpoint, because it wasn't immediate, obviously. There's again how science was able to find another break on the T cell. And this is a patient, one of the first patients who'd failed everything. This is what we used to do for these patients. We gave them a high dose interleukin-2. This patient actually already had ipilimumab. And this is a big tumor mass here. Well, that's cancer. This is a tumor in the liver, all cancer. And then what happens is on therapy, that big mass, it's a CAT scan in the chest. This all normal along goes, and the liver lesion dramatically improved. So now we had another big advance without the toxicities that were associated with the first class of drugs. Well, if one drug is good, maybe two drugs are better. This is the first report of combination. I'm showing you a couple things. This is called we call this a plot in which we look at not just regression. This is the shrinkage of the tumor, but how durable they are. This is not just the fact that tumors are shrinking, but how long a patient can stay on study. This is weeks and weeks of combination of Yervoy and of Tivo. And then multiple masses on the chest wall. All those bumps there are cancer. And you can see they all go away by 12 weeks. And this is a lot faster than we showed with single agent IPI. Again, when you added PD-1, you get these dramatic regressions, not just regressions, but stability, because we'll measure that every couple of weeks to see how long they stay in remission. And this is one of those patients. So this is, again, a patient with extensive disease, bad cancer. Now we know we use combinations of therapy. So where are we? This is a publication, not to know how to interpret this. This is the 10-year survival. So we're over 10 years out from the first studies, a decade. How well the patient's doing. Well, we didn't really anticipate this, but now at 10 years, this is the nivolumab and IPI, this is Nivo. At 10 years, called the Kaplan-Meier curve, half of our patients are alive cancer-free. They're cured. So we've gone in 10 years with a survival of 6 months to the survival in metastatic disease of 10 years at 50%. Now, I show this to my medical students. They go, Dr. Schwartz, that's great. What about the other 50%? Okay. We've made great strides, but we're not curing cancer in everybody. And that's still the challenge. How do we make it not just 50% in 10 years? How do we make it 100% in 10 years? And that's really something we need to work on. Just to review the toxicities, you add the second drug, the Yervoy. This is the percentage of patients with toxicities of the gastrointestinal type, diarrhea. Nivo by itself, which is the PD-1, much less. The question always comes up, do you need the second drug? Some people do, some people don't. That's a discussion with oncologists. Who gets doublets, who gets singlets? I'm not going to go into that. Maybe Dr. Mangle will bring it up. I'm not sure, but it's a challenge because when you add that second drug, ipilimumab, you're asking for trouble. You're going to get diarrhea. We have ways of control. Now imagine this 20 years ago. We had no idea. We didn't even know we were going to get diarrhea. We didn't know what we were going to do. We had those first patients therapy. We didn't know what to expect. And those first weeks, it was a nightmare. Trying to figure out what we do. We'd have meetings every day. We get together. Okay, this guy's got diarrhea. What do we do for it? We gave him Imodium. That didn't work. We gave him syringe. You got to give him steroids. But you want to avoid steroids because steroids suppresses the immunity. Pandora comes out of the box. We're putting Pandora in the box. Not good for the treatment, but good for the patient to avoid the diarrhea. So it's a challenge how to manage this. Which comes first? I mentioned now two things, targeted therapy and immunotherapy. Okay, so if you have a BRAF mutant melanoma, what do you take first? This is always a big question until a study was done. It was published by Atkins, a friend of ours, in Journal of Clinical Oncology. And what he did in the study is half the patients started immunotherapy first, and half the patients started that MEK-RAF combination. This is the BRAF and the TREMI, BRAF-MEK. Ipi-Nivo, CTLA-4 PD-1, randomized, equal. And if you progress, you crossed over. Bottom line is, in terms of 2-year, we don't have an update yet, 2-year survival, 72% alive with the combination getting immunotherapy first, and 52% alive getting BRAF targeted therapy first. This is for BRAF mutant melanoma, not for wild type. So again, so the standard of care today is everybody who starts today with, you have a metastatic BRAF melanoma, you start with the combination of immunotherapy. If that doesn't work, then you go to the 2-drug therapy. We're giving it now in earlier stage disease, that's advanced stage 4 disease. Now we're giving it to prevent recurrence after early stage resection. We call this adjuvant therapy. This is again a Kaplan-Meier curve, and you can see that when you compare Nivo to IPI, those who got the PD-1 versus the IPI, they did much better curability after surgical resection than those who got, Nivo was better than IPI, but overall compared to before, this is a huge advance. 80% alive at 2 years cancer-free with stage 2, stage 3 disease. Now we give it even for stage 2 disease. So earlier the disease now, as well as more advanced melanoma. Okay, we can treat melanoma. We're getting better, but we're not curing it. In half, it's better than I ever thought possible. But remember, we have melanoma as a preventable disease in the summertime. And when you go to the beach, now I go to the beach, and you go to the beach, and it's Cleveland's cloudy. I really got here like 2.5 years ago, and you go to the beach and you forget, and you leave that hat in the car, and your sunscreen's behind, and you go, oh my, and then 2 hours later, the clouds are gone, and it's pretty hot, right? So you can't forget your sunscreen because, I think we always forget it. We can't forget it. We shouldn't forget it. I could say this summer, the Cancer Center, I don't have a slide on it. We have a program we've initiated in Cleveland and the surrounding counties called Stop the Burn. So if you had a public pool, you may have noticed we have kiosks working with L'Oreal, Poussey, and they supplied free sunscreen to all the patients in the Cuyahoga and all the surrounding counties. And it's a collaboration we have, an educational program to address the issue of making sunscreen available to all people in Cleveland and the surrounding counties of our catchment area. In fact, our catchment area, if they take this, all the counties, the Cancer Center represents 4.1 million people. So we have responsibility for a lot of people in this county, in these counties, not just the city of Cleveland proper. So research, I think we scratched the surface. We're doing a lot of research. How do you do it? It's almost my final slide is old days, we take the melanoma and put it into a warring blender. You make kind of a slurry and we'd analyze this, but you look at that's a tumor. You have millions of cells, they're all different. You have melanoma cells, you have surrounding cells, you have immune cells. It's a mixture of everything. It's a grab bag. What do we learn from that? Not a lot, except kind of the gestalt. Well, can we take every individual cell and make like a fruit salad? Can we individually analyze every single cell in the tumor? So we have technology that we're developing a case, which we can take the tumor, heat it to the level of the sun and explode it. But every single cell is preserved. Then we can take each cell on this map and analyze it individually. Now we begin to understand what happens in every single cell. They're all different and how they talk to each other. Well, the single cell RNA-seq. We're going to be doing this eventually in every cancer patient's case. I want to do this at every cancer patient in the United States. In fact, we had a big meeting yesterday, getting all the cancer centers together. We're 54 of us. There are 2 in Ohio, Cleveland, and there's 1 in Columbus. Can we get all the cancer centers across the country and do this technology on a wide scale level and make it available to every single patient and physician? And we analyze all these cells and find new targets, new pathways, and work with pharma to develop or university to develop new drugs. That's my vision. We'll see, it's going to happen. I've got already the banks of Cleveland, I can't tell you which ones, are going to invest in this here in this community. And I have other corporations who are talking to me about making this a vision. So everybody has the potential to discover in their tumor what makes it grow. We know there's BRAF, we know there's PD-L1. There's got to be something else. So the other 50%, what are they? We're going to figure it out. And we're going to figure it out here in this cancer center. So more research needs to be done. We're advancing the tumor. We got to look at the tumor microenvironment. I think we have new technologies we can use. Everybody should be in a clinical trial. I think that's important. If there's a clinical trial available to answer these questions, what is the next drug? What's beyond PD-1? What are the next targets? And of course, we need to invest in prevention because Ben Franklin said, prevention is worth a pound of cure. He said that 250 years ago. You know what he's talking about? Fire department, okay? He built the fire department, preventing fires. But we can say that applies to cancer. We have to prevent melanoma. It's not that difficult. We need to educate people what it takes. Okay, I'm going to stop there. Can I take questions now? Or should... Okay, fine. You can have a seat. Yeah, thanks. Oh, let me introduce you.
Thank you so much, Dr. Schwartz, for that talk. That was really nice, and that gives us a very good perspective into what melanoma, where we have come in melanoma so far. So I have Dr. Sheng. She's my partner in melanoma oncology, and she's our patient with melanoma. And here she is.
Right here, if it's okay. Is there a microphone here? Okay, great. So thanks for the introduction. That was a fantastic talk, Dr. Schwartz. So my name's Sheng. I'm one of the medical oncologists over at Seidman. I practice in Avon and also downtown at main campus. So today's talk's going to be on what do we do now if your melanoma has spread to other locations? So we're going to talk about what this means, what the workup could look like, and what the potential treatments could be. I'm hoping at the end of the talk that you know that there's a lot of hope, and that's why me and Dr. Mangla especially push towards getting our patients through therapy, because we can see that the outcomes can still be really, really good. So for a little bit of background, melanoma is the most lethal form of skin cancer. It can spread to all areas of the body. Unlike other cancers, it does have a proclivity for the brain as well, which makes melanoma a little bit special. The big risk factors that Dr. Schwartz also alluded to is UV exposure, but also some family history, lighter skin and eye color, as well as age. The American Cancer Society did a study that looked at the 5-year relative survival, and it shows that still now for patients with stage 4 melanoma, the overall survival is around 35%, but as we move the needle with having more patients go on immunotherapy and other targeted therapies, this is starting to become better, these numbers. So what workup can you expect if your doctor tells you, hey, I think that you have melanoma and I'm worried that it might have gone somewhere else. Maybe you're coming in with a symptom that makes them worried, like shortness of breath or some belly pain or maybe some numbness or weakness somewhere. So you can expect that we'll be getting labs, something called lactate dehydrogenase. I'll explain what all this means in a second. We'll also get some pictures to see where has it potentially moved to in the body. And that's a scan of the entire body, typically a PET scan that looks at activity levels in the body of cells that are turning over very quickly. We think about cancers being these aggressive cells that they're going to be dividing very fast because they're sort of these superior cells sort of dividing in your body. But we also can get CAT scans as well and look at the entire body if we can't get a PET scan. We'll also get an MRI of the brain as well to see whether or not there can be any spots there that could explain symptoms, or maybe you don't have any symptoms and it's just something that's starting to form. And then lastly, if possible, we always want a biopsy of one of these other sites or satellite sites, because while we do know that you possibly have the melanoma based off of the skin, we want to make sure that it's not anything else. And we take that tissue and then we can send it for mutation testing. And that's really important to drive what options you have for later. So Dr. Schwartz talked a lot about mutations and why are they important. How I always say is I take a step back and say, what is cancer in general? All cancer is a cell that was normal, in this case a melanocyte, a pigmented cell, skin cell, and when it went to go divide, it made an error in its DNA. And when that happens, your body's supposed to say, oh, that doesn't look right, and get rid of it. Well, what happens when these cells don't get rid of your immune system doesn't get rid of these cells. These cells start to divide more, get more mutations, and eventually becomes a cancer cell. And we know that melanoma cells especially can have certain mutations that develop, and eventually we know that some of these mutations can be targeted by certain therapies. So it just gives us more options and characterization of the cancer that you have. So what does this workup really tell us, right? We tell you to do all these tests, you're already nervous, you're coming into our office and we're saying, oh, well, let's take a break and why don't you go do all these tests? And you're just like, why can't I just get started with therapy? Why do we need to do all these things? And it's because one, we want to see where is the tumor. We know that patients who have multiple brain lesions, especially if they have symptoms associated like numbness, tingling, motor issues, sensory issues, headaches, they do worse with our therapies. We also know that if you have a lot of tumor sites, not just one or two, that also pose a bad prognosis. And if you have an elevated LDH, which is that blood test, which is a marker of how fast those cells are dividing, if that's really high, then we also know that your cancer is probably a little bit more aggressive, and also makes us a little bit worried that we got to get you to therapy pretty quickly. This workup also now tells us whether or not you're a candidate for some more local therapies where we can actually shorten the duration of medical therapies that you'll be on. So now you're told that you have stage 4 melanoma that spread to other parts of your body. So this is sort of how I think about patients when they come into my clinic. So the first question I always think about is, well, are they an immunotherapy candidate? So going back, what is the function of your immune system? There's lots of functions, but the two big ones are your immune system is supposed to identify any cells that aren't yourself. So we traditionally think of bacteria, parasites, viruses. Your immune system also is supposed to recognize any cell that's not perfectly like yourself and get rid of it. And its also second function is for healing. So we know that melanoma cells sort of harness, sort of put this brake system, like Dr. Schwartz alluded to, that prevents the immune system from actually doing its job, recognizing these cells. And so therefore these melanoma cells are able to continue to divide and become more and more aggressive over time. And this is sort of this dynamic, once again, of showing that as tumors all start from that one cell like we talked about earlier, but over time they become a little bit different, just like you're not like your siblings and your siblings aren't like your children aren't like your nieces and nephews aren't like yourself and the grandchildren are different. I say cancer cells are the same as well. So over time they all get different characteristics and some are a little bit better than others, and the ones that are better or more advantageous start to develop and grow and seed to other places. Melanoma starts at the surface of the skin. So over time, your cancer cells are like, well, why am I stuck on the skin? There's not a lot of space here. There's not a lot of resources here. Why don't I grow deeper into the body and spread to other areas? And so we know that cancer cells in general, both locally, regionally, and globally, sort of suppress or evade the immune system in multiple different ways. So how does immunotherapy work? It takes that brake off your immune system. So when your immune system is globally activated, it goes back and says, wait, that cell doesn't look right. Let me try to get rid of it now. And there's lots of different agents that we'll talk about in a second. But when the immune system's activated, it's not against just the cancer, which is what we would hope for. It actually just globally activates the immune system. So it's just heightened everywhere. And so that's why, while I don't personally feel like the drugs themselves are that toxic, unlike like chemotherapy, which we traditionally think of for other cancers, it does have its certain types of side effects because it just depends if the immune system, when we like that match with the immunotherapy, gets too activated or just gets a little bit activated. So if it gets too activated, it can really attack any place within the body. And sometimes it can misfire and misread healthy cells as unhealthy cells. So that's where, when you look at your MI chart, you'll see all the itises that might appear throughout your patient chart. And that's, itis just means inflammation. So you get inflammation of the liver causing hepatitis. You can have inflammation of the kidney, nephritis, inflammation of the heart, myocarditis. And so really any place in the body can really be affected. So that's why we really have to think about, well, who can really qualify for immunotherapy? Really, I think are you healthy and fit? Are you someone who's biking, who's able to cook and clean, able to bathe yourself? Are you able to do most things independently, or do you require someone to help you? That's how I see it. Are you fit, or maybe a little bit less fit? And also the reasons why can't you do those things if you're not doing them independently? I also think about you globally as, like what other medical illnesses do you have? What are your other medications that you're on? Because if you're on a lot of things, you have a lot of subspecialists and they're having a hard time controlling lots of different parts of your health, you might not be able to withstand the therapies if you were potentially to get one of these side effects. And then especially patients with autoimmune conditions like Crohn's disease, lupus, ulcerative colitis, they weren't included in any of the studies that led to the approvals of these drugs. Why? Because these patients are known to have a heightened immune system. So therefore, if you give them more drugs that heighten their immune system, maybe that's not going to be so great. It might flare those underlying other comorbidities. And then lastly, if you're on any therapy that requires a steroid dose or an immunosuppressive agent that's equivalent to prednisone 10 or less, 10 or more, you probably shouldn't really go on this therapy because once again, you already have a heightened immune system. But two, it probably would make these drugs not work very well. And we don't really know whether or not they would be that effective. So after that, I think about, well, can your tumors be resected? So even if you have cancer that's moved to another place, if you meet one of our surgeons like Dr. Rothermel here and he goes, you know what? I think there's only 1 or 2 spots. I think I can get it. So that's really important to think about because if you're going to go to a surgery and patients always ask, well, why can't you just cut it out? There's only a couple spots. Well, yeah, if your surgeon says, yeah, I can cut it out, then that's great. But if they can't, the reason why you wouldn't want to go to surgery is because you might get a complication. One, you don't want any cancer left behind because then what's the point of the surgery? But two, what if you get a complication and you actually really do need a therapy with me or Dr. Manglo later and now you can't because you have a post-op complication, which we can't predict for, but unfortunately does happen. So if you meet Dr. Rothermel first and he's like, yep, I can cut it out, and or there's a reason why that has to happen, then what I can offer you on our end is therapy with immunotherapy for about a year, for 1 full year after. And the idea of it is that it's a cleanup crew. It cleans up any remaining cells that might be still floating around your body, even though your path report says that all your margins are clean, even though the scans say that there's no other evidence of cancer. We know that patients who had cancers that moved to other places logically have more aggressive disease and therefore probably need something to help clean and get rid of any other cells that might not be visualized because they just haven't seeded somewhere else. So the immunotherapy agents that are currently approved are single agent pembrolizumab or nivolumab that improve the recurrence-free survival, meaning that we know that it decreases the risk of your cancer coming back by about half, but it has yet to show whether or not it will actually improve how long you'll actually live for. So when I think about adjuvant therapy, I'll go back a sec, sort of the idea of giving a description to your immune system, right? You're sort of banking on the fact that your immune system can recognize any cell that doesn't look like yourself with really no description of what that cell even looks like. And we know that that has an improvement because your immune system can do those functions. That's what it's born to do. But what if we could give your immune system a roadmap of what to look for? And that's the idea of neoadjuvant therapy, which is a sandwich approach, meaning that we give still 1 full year of therapy, so that's no different. But what if we give immunotherapy before the surgery so your immune system gets exposed to the tumor before we cut it out? And therefore it learns all the characteristics of that cell, so when we eventually go for that surgery, your immune system and that cancer is removed, your immune system still has memories of what that cell looks like. And so if it sees it floating around in your body, it goes, ugh, I remember that cell. It really shouldn't be there. Let me now get rid of it. So once again, the purpose of that is to, one, improve patient selection. It also helps us guide subsequent therapies if you can respond to immunotherapy. And also it can potentially make the surgeries easier as well. So the approved neoadjuvant therapies are going to be, we can either do single agent or double agents. And sort of what like Dr. Schwartz was saying before, when you have double agents, you're going to have more side effects, right? You're probably gonna have more efficacy, which you can see here, meaning the outcomes, meaning when you go to surgery, what are the chances that you have no living tumor left in those samples? It's much better. However, you have to look also under the grade 3 side effects where it's almost double to triple amount as you add more agents. That can delay your surgery potentially. That can also lead to side effects where you might not be able to tolerate, or we might be too nervous to give you therapy after the surgery itself. So those are all things that me and Dr. Mingler are constantly thinking about when we offer these therapies. Okay, so now what if you're an immunotherapy candidate, your tumors can't be resected? What are we thinking now? So we're thinking of, well, now we know you can't get the surgery, that's definitive. So instead of doing 1 year of systemic therapy, we can offer you 2 years of systemic therapy. And the choices are going to be either this doublet, which is Ipi-Nivo, or Nivo-Rela, or single agent Pembro with nivolumab. So how do we decide what to give? So this is, once again, another big chart, but it's looking at the pivotal trials that led to these drugs approvals. And we know that Ipi is our most potent agent, but also our most toxic agent. In that trial, we included patients who also had brain metastasis, meaning that brain lesions, and that was something that was important. And Dr. Schwartz went in more detail, but look at that 10-year survival, and we found that patients were still doing really well, which is remarkable. We were thinking, though, well, this drug is pretty toxic. Can we find some other targets that might make it a little bit better? So there was a Relatively 047 trial that looked at relatlimab, which is just a different target than the Ipi, but still using Nivo as a backbone. And once again, we still have really good responses, maybe a little bit better tolerability, but this study didn't include patients who had brain lesions. And then lastly, there's also single agent, which once again, a lot more tolerable, but maybe the response rates are lower. So this is, once again, how me and my colleague, Dr. Mangler, think about what agents to choose when patients walk through our door. To make it more simple, this is really what I think about. Are you fit or are you not fit? And then how much tumor do you really have, and do you have a brain lesion? So if you're fit, but you have a lot of tumor and you have a brain lesion, especially if it's symptomatic, I'm really going to try to give you the most effective agent, which is going to be Ipi-Nivo, if I think you can tolerate it. If you're not so fit, but you still have a lot of tumor and I'm really worried, I'm gonna still wanna try to give you a doublet. So I'm probably gonna lean towards giving you Evo plus relatlimab. If we're saying that you're fit, but your tumor burden is low and you don't have a brain lesion, then once again, we're starting to go downwards. Maybe we can consider just one agent. Maybe we'll give you two, just depending on where the location is. So what if your cancer is not resectable and you're not an immunotherapy candidate? Well, then this is when all those mutations come into play. We send this off of blood and tissue, and we try to see what mutations exist in your cancer and what has been treated already outside of a clinical trial. So this is all standard of care options and what combinations we can give. And so the slide's really to highlight that if you have one of these mutations, we still have a therapy that can target something very specifically for your cancer. And this is what we're really looking for. These results usually take about 7 to 10 days to come back after we send the genetics. And so for patients who have a stage 4 disease, Dr. Mangla and I are sending these right away. So we have them just in case for later on, but we always start with immunotherapy first. And also these drugs, unlike immunotherapy, don't have a finite amount of time that you'll be on them. So they're just until your disease either grows or you can't tolerate them for some reason. And then if you don't have a target, or let's just say that you went through all those lines, you went through immunotherapy, you went through targeted therapy, there is this newer set of drugs out there called TIL therapy or tumor infiltrated lymphocyte therapy. And this is the idea is that if we take those T cells out of one of those lesions in your body, those T cells should already know what that melanoma really looks like, right? Because it's coming from within that tumor itself. So we extract it, we take those T cells and put it into a lab, give it some extra food and juice and make it grow really, really quickly. And then we give the patients, we admit the patients to the hospital, we give them really high dose chemotherapy, and then we give them back these T cells. And then we see whether or not patients will do better. And we have found that in the phase 3 trial that has 73 patients, that patients really did do better when we gave them this therapy. It's a lot harder of a therapy because it requires high dose chemotherapy. So you have to be really fit to go on to this therapy because all the patients had side effects, fevers, chills, low blood counts from the chemotherapy itself, and it requires an inpatient stay. So this is sort of the newest thing coming out that is available to patients. So it's something that we're opening at our center in the fall, and so we're really, really excited about this. And then lastly, just like Dr. Schwartz alluded to in his presentation, that we do use chemotherapy still, but it's not a great therapy for the treatment of melanoma. And so we usually reserve it once you've gone through lots of different lines of therapy. We never use it first line, meaning like right up front when you first get diagnosed. But it is technically still an option, though we try to lean towards clinical trials before we go towards chemotherapy, just because we know sort of track record that it has already. So the big takeaway point that I hope you got from my talk is that even when melanoma has spread to other parts of your body, you can still do really well. And so that's why we push really hard for patients to go on therapy if they can tolerate it, because we've seen lots of patients that we didn't think were going to do well, do really, really well and become independent again. And our job, me and Dr. Mangla especially, is to get you to tell you why you need to go on therapy, educate you on what therapy we think would be best, but also to get you through your therapy because the toxicities are definitely real and can be hard to manage. But you can still have a great quantity and quality of life, which are the two points that me and Dr. Mangla always try to emphasize when we treat patients, that we want you to live longer, but we also want you to live well during the time that you're with us. Right. Thank you.
Thank you, Dr. Sheng. That was an excellent summary of how we treat melanoma. It's a very convoluted road. But now I would like to welcome Dr. Mara Beverage. She's in our Department of Dermatology, a senior attending physician. And she and I trained both at the same time in Chicago, although we didn't know each other in Chicago. But yeah, so I have that connection with Dr. Beverage. So Dr. Beverage, please.
Thanks for that welcome. Yeah, I'm a dermatologist at University Hospitals. I see patients at main campus and in Beechwood and Solon. And so I'm going to be talking to you about dermatologic surveillance. So the role of the dermatologist As you've heard, advanced stage melanoma, the treatments are getting better, but they are still not curative. If we can't catch melanoma early, and the vast majority of melanomas start on the skin and are visible, so if we can catch them early, the treatment is much better, much more curable, much easier. All right, so today I'm going to be talking about the role of the dermatologist, signs to look for melanoma on the skin, and then melanoma risk factors and prevention. All right, so you're a dermatologist, you're coming for routine skin checks. We're going to be looking at your skin, and the interval is typically every 3 to 12 months. If you've had melanoma or you're high risk for melanoma, you don't want to be going more than 1 year without seeing a dermatologist. And sometimes we see people more frequently, and that depends on the stage of your melanoma, how far you are from your melanoma diagnosis, and again, other risk factors like how many moles do you have, how much sun damage do you have, what's your family history. So you and your dermatologist will decide that one together. At those skin checks, you're looking for if your melanoma has come back, if your melanoma has spread. Sometimes the signs of that are visible on the skin. You're looking for a second primary melanoma. People who have already been diagnosed with melanoma are at higher risk for another melanoma. And people who have already been diagnosed with melanoma are at higher risk for another skin cancer. A lot of the risk factors that put you at high risk for melanoma put you at high risk for other skin cancers as well. I also find for my advanced stage melanoma patients, as you've been hearing with a lot of these newer therapies that we have and the toxicities or the side effects that you can get from them, actually the #1 side effect affects the skin. So checking with your dermatologist regularly can help you manage those side effects and maybe even prevent some of them. So I spend a lot of my visits talking about that and helping patients with that as well. And then education, what are you looking for? How do you help yourself? How do you help your family? So early detection. I have had some patients flat out ask me this, why am I seeing you? I'm getting scans. My scans will find the melanoma. I don't need to see you, which I thought was a great question. Your scans are really good at detecting advanced stage melanoma, but usually the melanoma has to be about 1 centimeter in size for the scan to effectively pick it up. If your melanoma is going to start on the skin, I can catch it when it's much smaller, when it's about 1 millimeter in size. So again, trying to catch that early stage melanoma, that's why you want your dermatologist to be part of your team as well. How are we going to catch it? You do want to try to find a board certified dermatologist. So there are a lot of dermatology practices that to increase access have physician's assistants see patients as well. If you're high risk for melanoma, you want to see a board certified dermatologist. So this is someone who's gone through medical school, they've gone through a certified dermatology training program, and they've passed their boards. The American Academy of Dermatology. Oh. Okay, put that logo. The American Academy of Dermatology. That's a great resource. That's a dermatologist professional organization, and they have a tool on their website to find a dermatologist that can help you check and make sure that you've found a dermatologist who's highly trained and well trained to help you with what you need. That dermatologist should be using a dermatoscope. The dermatoscope, actually the newer ones, they've, with a lot of technology, about a lot of powerful technology in a small looking thing. I think a lot of my patients just think I'm using a flashlight. It's more than that. There's a filter in there. It polarizes the light, which actually lets me see through the first layer of the skin, the epidermis, even into the top layer of the second layer of the skin, the dermis. And that's where most of our pigment cells for our moles and our melanoma live. So I can actually get a pretty good idea of what that mole is looking like just with this light. And then photography. I have tools to take photography in the office, so I will use that to monitor certain patterns that I think need a little bit of a closer eye. But there are also tools for you to use yourself at home. You go in your app store, there are a lot of different apps to do. This is the one that I tend to plug, OHSU. It's Oregon Health Sciences University. They've made a pretty good mole mapping app. It is free. Unfortunately, it's only available for iOS, which is why I have the Apple Store logo on there. But it's free. They ask you to participate in research. So the photos that you upload, they might use that for research. It's de-identified. They explain it very well. You don't have to participate in research to use the app, though. You can also use it without doing that. And it's just an additional tool. The app is not going to tell you that something looks like melanoma, but it's a way for you to help track your moles. And then patients always have their phones in the office. So then if I have a patient who's using this app, I can use it too. And if we're unsure if a mole is new or changing, we can kind of look at that together if I haven't already taken a picture of it. All right, so what are the signs? What are we looking for on the skin? Simply put, you're looking for the ugly duckling and the old friend that's changing on you. Popular TV show Friends, and then over time they change. I mean, I think they've changed pretty well, but that's simply put what you're looking for. So if there's a spot on your skin that just doesn't look like anything else on your skin, either because it's darker, it's larger, the border, the size, or if there's a spot you know you've had for years and years and all of a sudden that one's changing. It's growing, the color is different, the border is different, something about it is different. These are the technical kind of criteria that you're looking for. So the mnemonic is the A, B, C, D, E's of melanoma. A stands for asymmetry. So as you can see in that A picture, the right half looks darker than the left half. B is border. That one, when you try to draw your finger around it, you find your fingers kind of going in and out. That's an irregular border. C stands for color. There are about 4 shades of brown in there. So if you can't quite detect that, you kind of start with one shade and then you kind of go through and see, and yeah, they're like about 4 shades of brown there. That's too many. 1 or 2 shades of brown is fine. More than that is not good. D is diameter, greater than 6 millimeters, or the top of a pencil eraser. If you don't have pencils in your house anymore, I say the top of a quick point pen. And then E is evolving, something that's changing. Tricky part about this is these rules apply to moles and melanoma. Not every spot on your skin is a mole. There are other types of skin growths as well. But, that's why you need a dermatologist to help you with this. And together you'll figure out which ones are worrisome signs and changes, which ones are normal ones. I always tell my patients it took me 3 years of intensive training to learn all of this. It will take you a few visits. But I do find that most of my patients, after a few visits, start to get the hang of it and feel more comfortable. And I say you only have to learn one, so that makes it a little easier. All right, these are the friendly moles, the friendly patterns that are fine. The most common ones are brown, pink, and two-toned. So again, 2 shades of brown are fine, but as you see in these two-toned moles, it's pretty symmetrical, right? The one on the left is darker in the middle, lighter at the outside. The one on the right is a little bit lighter in the middle, darker on the 2 shades are fine as long as they're still fairly symmetrical. The eclipse and the targetoid or cockade are what we'll call the fried egg pattern. Those are also pretty normal patterns as well, but not as common. And then this is what I'm looking at with my dermatoscope. So this is the level of detail that I can see. And so these are some of the patterns that I'm looking for. You're not going to be able to see them, but I can. The one on the left, that reticulated pattern, that's my favorite. Reticulated or lace-like, that's a nice stable pattern. That's the way the melanocyte, the pigment cells look when they're sitting in the proper part of the skin. This middle pattern, the globular pattern, that's a sign that it's growing. That might be okay, and it all depends. So if I see that middle pattern, that globular pattern in a child, you can see those globules are nicely distributed around the edge. This is normal for a kid. Their moles are still developing, they're still appearing. I'm perfectly okay with this. If I see that exact same pattern in a 70-year-old, I'm much more concerned. They shouldn't be having moles that are growing or changing. I'm much more likely to remove that one. And then this mixed pattern is mixed. This is one that often takes the most conversation because I just can't tell. You can kind of see here, there's some areas where they're globules, there's some areas where it's reticulated, there's some areas where the pigment just seems to be fading and smudging out. That's a pattern where I don't know immediately by looking at it, and either time will tell, so we take a photograph and we monitor it closely, or we just remove it and take it off to find out under the microscope. And that's why I need my dermatopathologist to help see a better detail after we've removed it. All right, so melanoma risk factors and prevention. So we've heard a lot about risk factors, and here's another slide, but the way I think about it is, unfortunately, a lot of the risk factors are things outside of your control. The biggest thing that increases your risk is what runs in the family. So on the left side here, hereditary melanoma, there are these genetic syndromes or gene mutations that can run in the family. Fortunately, they're incredibly rare, but if they do, you and your family are at really high risk for melanoma. And that's why, to try to screen for that, we asked, does anyone in your family, have they ever had melanoma? We use that as a marker to see who's at high risk. The number of moles that someone has, that's another risk factor. The way I think about that one is when your body is just making extra pigment and extra moles, if that process goes wrong, then that's melanoma. So people whose bodies just naturally make more moles are at higher risk for having a mistake happen that could turn into melanoma. And then the last one, even though it looks like it's the smallest, it's kind of has the smallest increase in risk for the individual person. This group, this is what causes most of the melanomas that we see. And these are what we'd say are the preventable melanomas. So it's all the sunburns, the sun damage. And so this is why we talk about it so much. It causes most of the melanomas that we see. And it's the one thing that you have a little bit of control over. So how can you help yourself? Sun protection tools, sunscreen's the one that's been talked about the most, but it's not your only tool. But if you are, for sunscreen, you gotta make sure you know what you're looking for. Unfortunately, most of the sunscreens on the market have these things. The days where I know you used to go and it'd be like an SPF 8, can't buy that anymore. Don't buy that. It's gotta be SPF 30 or higher. You want it to say that it's a spectrum, which means it's causing both UVA and UVB, which are the types of sunlight that cause most of the skin cancers. And it is helpful if it says that it's water resistant. It'll just help if you're sweating or if it's rubbing, kind of help keep that sunscreen in place. 1 ounce of sunscreen or enough to fill a shot glass is what you need to cover the whole body. And you do want to kind of keep like every 2 hours in your mind. So if you're going out again more than 2 hours later, you should be putting another layer on. If you think you're going to be out for more than 2 hours, you should be bringing some with you to reapply. That's really hard to keep up with. So I am a big fan of the sun protective clothing on the right side of the screen there. Hats, long sleeves, long pants. And so they're more and more out there and they're becoming more and more comfortable. I always tell my patients, if you tried it before, but it's been a few years, please give it another try again. And then where to look for them. Hats, I think, are really tricky. It's very, very personal. What hat looks good and feels comfortable on what person. So I say, just look anywhere. Sometimes it's the gas station, Target, like a museum gift shop. Like I have heard patients find their favorite hat at the most random places. So whenever you see a hat stand, just take a look and see if you see a hat that you like. You do want it to be a wide brim. A baseball cap is shielding your eyes. It is not the best sun protection. It's better than nothing. But when you see those baseball players and they've got that tan line or that's showing you where they're getting the best protection, which is really just shielding their eyes. It's not shielding your lower face, your neck, and the back of your neck. The sun protective clothing. So all clothing is a little bit sun protective. The benefit of something that's labeled sun protective, it's lightweight and breathable, but it's as sun protective as a heavier fabric. So if you think about linen, linen's a nice lightweight fabric, but if you hold it up to the light, you can see that light streaming right through it. It's not very sun protective. If you think about your thicker cotton jeans, unless they're really worn out, you hold those up to the light, no light's getting through it. So the jeans are really sun protective, but they're hot and hard to wear on a hot day. So a sun protective clothing should feel light like linen, but protect you like your jeans. Coolie Bar is a good company. That's all they do. They make sun protective clothing. That's it. And the outdoor clothing companies do a really good job now of making nice, comfortable sun protective clothing. So Columbia, REI, Patagonia, Land's End, those are the places where I tend to steer people to look for these things. And start just by buying one, see how you like it, see what you like, what you don't like, and just slowly keep trying to improve your wardrobe. In addition to skin checks, you want to make sure you're seeing your dentist regularly. It's rare, but you can get melanoma in the mouth, and the dentist can see that the best. Regular eye exams, likewise, it's rare, but you can get melanoma in the back of the eye. So a dilated exam with an eye doctor, regular gyne exams. And for women who are not seeing a gynecologist regularly because they're too young or too old, your dermatologist can often do those exams as well. And we do recommend that all first degree relatives see a dermatologist for a skin cancer screen. So that would mean, so if someone's been diagnosed with melanoma, their first degree relatives would be their siblings, their children, and their parents if they're still alive. So in summary, follow regularly with your dermatologist. Your dermatologist is a helpful member of your team. Use your sun protection. Again, most of why you had melanoma was outside of your control, but we want to try to do everything that we can. And the sun protection is kind of the one risk factor that we can control a little bit. So every little bit helps. And if you see something, make a note. We're holding on questions.
Thank you so much, Dr. Beverage, for that educational talk. It is really, really important for us to have skin education. And now we are going to have a questions panel, so we'll be pulling up tables. And we'll invite our four panelists to please come to address some questions which we received online. Any in-person questions anybody has? We'll first address the in-person. Take those. You want to have a question?
Dr. Mangla.
And any questions, if I cannot address it today, either online or in person, then please feel free to reach out to AIM and we will be happy to answer those questions as we go along. Thank you.
Yes. Oh, yeah. Yeah, great. Try to catch them before they need to go to you guys. Want to make sure.
Sorry about the brightness. You're on camera, but okay.
Do they need to move perfectly?
Okay.
They're centered, they're great.
All right, so this is the first question we got over here. It's can the break mechanism be determined in each patient? And can we select immunotherapy based on the result? So Dr. Schwartz, let's start. So the break mechanism which you described on the T cells.
So it's really not a tool we use to determine the optimal therapy. It's just PET imaging is part of standard of care. Use it even for staging a melanoma. So almost all patients with advanced melanoma will get a PET. It will show the tumor burden. I think that was a good point raised. It gives us a sense of how aggressive. I mean, those patients today would get double therapy because there's such a large tumor burden, even in the absence of brain metastases. So what it does, it gives us a better sense of the extent of the disease and does give us a sense of how aggressive our treatment should be in terms of how to tailor the therapy. But we can't really individualize every single lesion. The value of this, though, it does allow you to monitor the disease. So to see this, massive, highly metabolic disease, and you're going to do aggressive immunotherapy, it should resolve within a relatively short amount of time. If you don't see the resolution of that heavy metabolic tumor, or things begin to develop new lesions, you're on the wrong therapy. So yes, in a sense, the more extensive disease metabolically will guide you to more aggressive therapy. And also you can use the PET imaging to monitor the response to treatment over time. And if it doesn't get better, then you're on the wrong treatment.
Thank you so much, Dr. Shah. So this question is for Dr. Beverage, and I actually also want to know this. Do we know if the UV lamps at the nail salons may increase the risk of skin cancers?
No, I actually, one of my co-residents in residency tried to do this study and no nail salon would let her come in to run the study. So it's, kind of similar to tanning salons. There's not been a lot of cooperation with people outside of a dermatologist's office who use this equipment. So probably it's a really low dose and a low amount. So we'll kind of tell our patients, it's probably a good idea to just put sunscreen on, and again, the water resistant one. I know it's going to get kind of washed off a little bit with the soak. So it's probably a little bit, but we haven't seen like big cases of melanoma around the nail in patients who get gel manicures all the time for years and years and years. But yeah, there is UV light there.
Thank you. And this is for Dr. Beverage again, can you share any tips for those who have darker skin for skin checks?
Yeah, you're right. I didn't get, depending on your ethnicity and your skin type, we can see skin cancers in different parts of the body. So darker skin types, and different ethnic groups. So Hispanic, of African descent and Asian descent, have lower risk of melanoma, but not zero. A lot of those melanomas, especially in darker skin types, are not so much sun related, but what I'll call the bad luck melanomas, where it's inherited or a genetic mutation that went wrong. So again, we're looking at those risk factors of family history, and if you see something that you're worried about, so lower risk for melanoma, but never zero risk, no one zero risk. Acral melanoma is a subtype that we tend to see more in people of darker skin types. And those are then melanomas that we see on the hands and the feet. So simply put, a skin sore or something that's not healing and can't be explained by something else, that should be looked at and potentially biopsied.
Thank you. And Dr. Schwartz and Dr. Sheng, this is for you. Is there any is there any data if immunotherapy before or none affects the success of TILs, the tumor infiltrating lymphocyte therapy? And does tumor infiltrating lymphocyte therapy work for all kinds of melanoma?
Yeah, that's a great question. The study was small, it was only 73 patients, but it included all lines. So there were some patients who actually had immunotherapy first. There was also patients who got it first line. And so I think it was too small to really divide out who did better than not, because it was only recently approved. That's how I see it. So I just think that in general, I still would opt to start with immunotherapy if I had to, as the best option. And it also allows lots of versatility in where you can get it done, which I find is very important to most of our patients. A lot of patients don't want to come to main campus. Patients aren't always fit enough to get the TIL therapy. Not all patients want to stay in the hospital to undergo the whole process to get the TIL therapy. And it takes a couple of weeks to actually get it set up. So it's not something that can start right away. Most of my patients who I see in like Avon, they're not driving down. They would try almost anything to not have to go downtown to come get a therapy. So I sort of reserve it for when I'm starting to think of, hey, my patient still looks really good, but I'm a little bit worried, like Dr. Schwartz alluded to, that they're starting to not do well. Maybe their scans are starting to show growth or new lesions. And then I'm starting to think about it a little bit faster.
I think TIL therapy is complicated. It's toxic. It's reserved for patients who really are failing all first and second line therapies. We know that immunotherapy should be started first. In fact, now we move to, we call it as neoadjuvant, that is before surgical resection, because if you have the melanoma there, it's sort of like the T cell will see it as foreign. If you take it all out surgically and give immunotherapy, well, there's nothing for it to recognize. You need that recognition for the T cell to be activated. So the value of having treatment with your disease still there, which sounds like, oh, I want it out. I mean, the first question, oh, it's melanoma, get it out. But that's not the right decision anymore. The decision really is, let us stay there, give the immunotherapy, recognize the tumor is foreign, and then start the treat and get the treatment going, and then resect. In fact, there's some patients who may not need surgery at all because the tumor goes away completely. I mean, we may get to the day we don't even need surgery. We've seen that, in fact, in a disease called rectal cancer, where the tumors have such a high, we call foreign body expression. They have something called microsatellite instability, where the tumor is so like foreign, you give immunotherapy, goes away completely, you don't need surgery. So there are debates, and Dr. Rothermel can talk about this, about, what is the future for surgical resection for complete responses for melanoma? Do we need to actually even take out the tumor? Do we need to do lymph node biopsies to stage it? There's a lot of questions going on about the surgical incorporation, integration to melanoma. I think we're certainly not there yet to make those final decisions, but TIL therapy, getting back to that point, is something we should only reserve for after all the other treatments fail. I think it's something that's new. It was around a long time. I mean, there were these therapies, but they've only been recognized for the value in the last 2 to 3 years.
Thank you. Thank you, Dr. Schwartz. And I would like to thank everybody who's sending in questions. These are all great questions. Dr. Beverage, this is for you, and I think I had another person asking the same question. If a patient develops a melanoma, at what age should their kids start seeing dermatology? And this, on the lines of the same question, when should any kid start seeing dermatology?
Yeah, that's always hard. I mean, on one hand, you can say if you've got a question, then just bring them in. Often your pediatrician can help with that too. Pediatricians are actually really good with a lot of skin things. Kids have a lot of skin things, rashes, just with routine skin, like viruses, eczema. So your pediatrician can really help you with that. But I do tend to like to see kids during their high school years. That way you kind of catch them before they disappear off into adulthood. And you know, you can kind of bring them in with their parent, whether their parent stays in the room or not. They can just see a dermatologist, and a skin check is not a scary thing. They kind of know what it is. But mostly we're doing these screenings more regularly in adulthood. But yeah, if you've got a question, if you're not sure, start with your pediatrician, and then you're always welcome to see a dermatologist as well.
Thank you. And Dr. Sheng, this is for you. If you could please explain, why does the LDH increase in melanoma?
So LDH is a marker that's been used in lots of solid tumors. All it's just within the cell and tells us that the cells are dividing very, very quickly. So therefore, when the cells divide really quickly, cells also die quickly, and therefore it can release the contents, which is LDH, and therefore that's what's elevated. So you'll see in a lot of cancers, you'll see that that's a marker that we use, and it's really just to let us know that cancers are dividing quickly. It doesn't tell us more than just that. So that's why we use it.
Right. The next question came in for Dr. Beverage is the intermittent skin exposure produce the highest risk of having a melanoma, or is there a risk chart that I can predict?
Yeah, for melanoma, it is that those severe blistering burns, particularly in childhood. So this will be another thing I find myself saying, never to add more guilt onto a parent, but try to protect your kids as best you can. It's healthy to be outside and be active and do all that good stuff, but just try to make sure that you've got all the sunscreen. I mean, I send my kids to camp and school with like 3 different things of sunscreen in their bags, a sun hat, a sun shirt. Do they wear and use all of them every day? No, they do not. But you just try to help as much as you can. But it's like different studies will say different things, but 3 or more blistering sunburns in your childhood years really increases your risk.
Right, we still have some time to go. So just one more question is it guaranteed that if you have had a melanoma, it will come back or another form will develop ever again?
So, and the answer to that's no. I'll show you data in my presentation about the reality that there are a lot of people that are cured of melanoma with appropriate upfront treatment. I think one of the dangers is that it's not a trustworthy disease. I say this all the time. And being able to prove that somebody has achieved a cure, if I see a patient, we get through surgery and there is no spread of disease, and I say, there's a good chance that this won't come back. But the only way I can prove that is that 100 years from now, if you die of natural causes and we realize you'd never had melanoma again, we did it. We did it. So getting to that is just a process where we always have to be vigilant about what melanoma is.
Right. And you have one more question over here. If I have severe side effects on Ipi/Nivo, how long will it take for us to continue before trying a different therapy?
Yeah, that's a good question. I think it depends how, so the big marker that I see is one, how much disease do you really have and what's the side effect that you really had? If it's severe enough that you're in the hospital, you're seeing multiple specialists, you're on lots of different types of immunosuppressive therapy, you probably should never see the combination of ipi-nivo again. If you respond very quickly to immunosuppressive therapy and we can tailor it off, I sometimes consider a retrial. And there's sort of lots of data looking at this. There's sort of three ways of going about it. One is if we can get you down to the steroid dose of about 10 milligrams-ish or less, sometimes we'll just keep you on the 10 milligrams and treat you again and see how things go. Or we drop one, so we drop the ipi and we continue with the nivolumab alone. One thing that I don't think either of us went into detail is that ipi-nivo is just the first 4 cycles, and then you go on to maintenance of nivolumab alone. So it's really about, and a lot of that's because of how toxic it is. We know that 4 doses is what we're aiming for, but not everyone makes it through all 4, to be honest. And then lastly, we can always try to switch to something else. And so that's sort of the algorithm we go through. The interesting thing about immunotherapy is it's just letting them match the immune system, but only 30% of the time will the same side effect occur again. So we can't really predict that it definitely will happen again. There's lots of patients I've sent to Mara before for severe dermatitis, and then I trial immunotherapy again and it doesn't come back. And then patients will say, well, how did this happen? I'll say, I don't really know, but I'm glad it didn't. And then we just try to continue. So I think the biggest thing is when you're on immunotherapy is that you have to communicate really well with your team, because we won't know if you're suffering or until you let us know or the hospital lets us know. We also can't catch it early and try to get control faster so you don't actually make it to that level where it gets so severe where we have to consider stopping therapy. So long story short, it's really individualized. And it's also based off patient motivation as well, like how much, it's a lot of it's conversation. Some patients really, really want to try again. And then I try to then think, well, if it's not going to be deadly, should I try again? And so there's a lot of conversations about it.
Thank you so much to our panelists for participating. This was a really good conversation. We're going to have a few more presentations, 2 more presentations, and then we are going to have one more Q&A panel after that. So please just stay with us. Thank you so much.
Feeling safe without me.
There was a real question about the break mechanism. What's that? About the brain, the tumor with melanoma.
Yeah.
So, yeah, right.
Yeah.
I was just saying.
Everybody
Great thing on your face.
Oh,
We don't.
Yeah, this is a-
Can someone talk to Jones? I need to set this close to.
Yeah.
Oh,
Well, I just.
He said he was on trials and. Same people on it.
Yes. I was sorry, I saw it. Sorry, I moved you. I was like.
You probably moved that here.
That's on that. It's a big case. That's a.
I don't know what the result is.
You'll see that.
Keep them on there for about 3-4 years. Everything except. He calls me and they was and I know. Right. Can't find them, but I'm just saying, back when I'm on it, it's
Well, yeah, like, I mean, I love.
He's a chair.
It's always about patients, right? And I think like.
Yes, that should say that she's.
You know, it's like an interesting study, I think. But like, these two guys, so you guys.
Yeah, no, it's hard to have some mind there because I just like the only is they should. I have to tell you, I do a lot of time. And I was looking. You know what, that's so true, and I used to work. And I'm around. It was, I'm sure, but it was like, but it's important. So what's your plan of care? Yeah, she was a great school teacher. She was a great teacher.
I never see that.
Yeah, I'm not sure, I don't think it's still. They switched out and they're flying now. Yeah. What you doing today?
So.
Right. Well, it's satisfaction too.
Yeah.
Good luck. Thank you.
I just introduced myself. I'm not okay with this.
Someone who's like has hired you to explain that.
She wasn't.
Your fault. My fault.
Yeah.
See what they got.
Yeah.
They open at 11.
So we don't understand why.
Yeah.
Wow.
So you made an offer, and so I. That's like, tell your, don't make it just.
Yeah.
So we have a service called Talk to a Medical Expert. Scholar Center, she's a PA, but works for John Hopwood, they do PAs. And so what she does is people write in questions about things that are going on.
That's right.
And she, will contact them via email or call them. But what she doesn't is make a series, and has been a series of that with her hand. And I go, why aren't you here? Why is she paying? She's giving sort of the same question. Right? And so she's always looking for
I should get on.
that would like to be her guest. So we can talk about things like uncle. Let's have a conversation about that and let's just like look in a way that they understand. And then there's, which means that just like does read there's family part of that. Clarify what. Should I start? Is this kind of thing?
Yes.
Well, I understand.
So.
No, they're always.
Oh, okay.
So it's just you in your office and her office and she has two.
Oh,
So that, yeah,
She understands.
so if they stick.
Yes.
I think it's.
It's great. But they're meant to be, connected. It's just the same. And then I want our office.
Line treatment,
Yeah.
well, that's what Grace was. Oh, yeah, they needed to get her stable.
Of course.
Salter better to start with the first, immuno, yeah. So I just find that interesting.
Yeah, the targeted.
Yeah.
Right.
So thank you.
And she was great. So like, that was a lot.
That you would.
I should look one.
Very good. I really just turned.
And if the old part has been better.
Like. Almost 3. She's outside of that. 2 a.m. Me. It's been a dream. I know, I thought she was sleeping would get like this. She's gonna sleep till she was like 5. Well, I think Greg's like now she's like,
I know.
I'm like, well, it's like.
I talked to the application I was talking to. You agree? The guy who's,
There's no, it's like stay over there.
said,
And I'm so tired, like, just.
he said for some reason.
Yeah.
Two-
Yeah. Like, oh yeah, I mean, that is right now.
Dinner, you know, she get a heart.
One was 10 days diagnosed. The other 10 days.
Surgery to get that, and then she said,
You can get a guy.
I was so we should put three.
The way that she liked
Um,
reflecting on like
Not just amazing, such,
but like us.
yeah.
Bless her, it's like.
So here I am.
I'm gonna kind of. I'm getting very like,
Okay, now.
and it's like just. What?
But yeah, this is not.
It's like.
We should.
Like.
I mean, yeah, that's all. So I'm sure for two.
You up for your card? Before I leave. I would love that.
I think that was what I said today.
Amazing. I'm very well.
Yeah, yeah.
Thank you.
September. No, really.
There we go.
I'm probably.
They put me.
Okay. All right, yeah, I'm gonna change it because I felt that here.
That might correct why it's not returned. When this is not my name is. That's it. I just hope patients put sunscreen on her. She said, I don't know, just wear sunscreen.
That's what that's fine.
I just, not just was something that's not, but it's getting my finding it so bad. I don't around. It's like I'm crying all the time.
Oh, it scans the screen.
Target there.
Right, the summer, it's like, it's cost for people.
Like, so they trying to. All right.
Doing all these. You know, a question that didn't come in, but I know. Yeah. Somebody is. Yeah.
But the name.
Yeah.
And then I push back.
So maybe eventually, I'm sure there's other things.
They did. Mango.
You gotta go.
Thank you.
See you later. You get a water.
And the next visit's with.
Because I am on.
At all those conversations.
George.
We went just gonna get way back.
Your mind's all.
Yes, yes.
We asked you.
Oh, I'm interested in seeing it. Yeah.
Oh, yeah.
Saying, don't forget.
We're in the news. I understand you.
So I spoke to him. He was supposed to go for
Yes. You just split it off.
I said that say yes.
Right, you put your name on
I didn't see that before. Thing already started.
No, they're already capped and so I just message me. It's really good place to go. I didn't.
Yeah, already.
You're lying, it's all, who's gonna wait it out till, say, look, they need me to come.
How's that? Some swag.
Yeah.
Oh, no. That's everything. Small on the shelves. Mention somebody.
When you called me.
All right, everybody, welcome back. We will continue here onwards with our Melanoma Symposium this morning, and I will introduce Dr. Rothermel. He's an associate professor in the Department of Surgery and chair of chief of section of soft tissue and GI surgery. Me and Dr. Rothermel almost started our careers together at university hospitals. This is my first job. I believe this is your first job as well. Yeah, and we together when we started, we had one clinical trial. And now we have almost over 18 clinical trials, and we have recruited nearly 150 patients, more than 150 patients in the last 5 years to clinical trials with lots of success. And but Dr. Rothermel has been instrumental in developing the surgical oncology program in melanoma, and he was the one who actually brought in the concept of sentinel lymph node biopsy. He's going to talk about that. So without any further ado, I'll have Dr. Rothermel take the stage, please.
Okay, thank you for the opportunity. I appreciate the introduction, Ankit. It is wild to hear these talks on the progress that has been made in treatment of advanced melanoma. It begs the question of why not treat everybody? Why not just everybody get a little bit of immunotherapy? And the reality is that we don't need that. Is this full screen? It looks a little bit one thing. Sorry. Thank you. All right, I have one disclosure that doesn't actually have any bearing on this talk. What I am going to try to educate you on is what we do as surgeons when patients come to us and what the surgical approach is for melanoma. Then what the benefits and risks of immunotherapy are for surgery patients. And finally, what is the harmony of surgery and immunotherapy? Most patients with melanoma present to me without clinical evidence of that melanoma has spread. So what that means is you come in with a biopsy site that has proven that you had a melanoma on the skin. But I can't find on my clinical examination any evidence of lumps, bumps, lymph nodes, or other things that represent spread of melanoma. And so when I think about this, there are perspectives on what I should offer patients. Most patients are getting a wide excision for their primary melanoma, not really most patients, everybody gets a wide excision. And the purpose of this is to decrease local recurrence and get the melanoma out of your life. But about 85% of people coming into my clinic will have localized disease. So the lesion on the skin. And in most people, cure is possible with surgery alone. So of those, most melanomas are thin or very thin, less than a millimeter in invasive depth. And that means that we really should consider what do we need to offer these patients. Those thin and very thin melanomas have a low chance of recurrence. So what do we offer if they have a higher chance? Well, we offer a sentinel lymph node biopsy. If I can't feel evidence of melanoma in a lymph node, it doesn't mean that it hasn't traveled. It means that if it has traveled microscopically. We need to take the first draining lymph node out to send it to the pathologist and have them do their due diligence, cutting up that lymph node in great detail and meticulously proving that there's no evidence of melanoma in it. Now, so the very low risk patients that come in with a thin melanoma or very thin, wide excision may be appropriate, but for those with higher risk or a higher chance that melanoma may be in lymph nodes, we use a sentinel lymph node biopsy. And this answers the question of has melanoma spread and do we need extra treatment? Now, how do we decide what to offer the people that come in? Well, if you have had melanoma or if you had a family member who's had melanoma, you have a pathology report that comes to you with this synoptic report. And that reports on dozens of features of that primary melanoma. Now, it is in many ways written in code. And the things that really inform me of what I should do are the Breslow depth, so that's the thickness of the melanoma. And then high risk features. And I apologize about how this is coming out with my size here, but high risk features of the melanoma. Things like ulceration, things like lymphovascular invasion or mitoses. Mitoses is when the pathologist looks at the slide and sees evidence of melanoma cells dividing. They count the number of times they see that and they report it. So we take all that information and we decide what to offer as a result. And the goal of our procedure is, number one, trying to cure melanoma. And like I said just a little bit ago, cure is the goal, but cure is not something that we can prove. And so we aim for it, we know that we can achieve it, and yet we take it with caution, knowing that melanoma can be quite sinister. So the additional goal of surgery is staging. Has melanoma traveled? And we can also, this blue line is supposed to be under regional disease control, not through it, but we can also decrease the chance that it shows up in a regional lymph node basin by doing surgery. And then there are other things for more advanced melanoma, surgical consolidation. So after you get treatment, removing anything that remains, or even palliation. If there are tumors that are causing pain, we can be involved as well. But I'm going to focus on the top three, and I'm going to show you some graphs here. These graphs show the likelihood of dying from melanoma based on the various stages that people start with. So each category or line represents the survival based on the tumor thickness and whether or not high-risk features are present. This graph in particular is showing the early stages of melanoma, stage 1 and stage 2, and these are patients that do not have lymph nodes involved. And so when we look at these, in this we see a dotted blue line that's arbitrarily set at 80%. I put this up here because some of the other graphs will have 80% at a different level, and it's hard to it's hard to look at that visually and perceive the difference. But down in this corner, we're starting at a 50% likelihood of melanoma-specific survival. And other graphs start at 0. So it's confusing. Nonetheless, what I want you to see here is that these blue lines show the thinner melanomas. And these are the patients with thin melanomas with or without high-risk features. And most patients do very well. Patients with the thinnest melanomas without high-risk features, 98% of them will be alive at 10 years and not have had consequences of that melanoma. So these are patients that we commonly do not recommend for sentinel lymph node biopsy because they do well regardless. We don't need to do extra surgery for patients that do so well without and have such a low likelihood of lymph nodes being involved. But that 2%, so this 1A group, right up here, 2% of patients within 10 years will die from melanoma. That is not a lot, but that is still very important to us. And that, again, is why we don't trust the disease, and we need you plugged in with your dermatologist, and we need to counsel you and educate patients to make sure that you just know what to look for, how to be in touch with your treatment team, and to know that we're always available. So the orange line, these are patients with intermediate thick tumors. And this shows that 90% of people will survive melanoma at 10 years. So still a very high rate. Now, as we go to what we call the high risk stage 2 category, these are patients without lymph nodes involved, but have thicker tumors or intermediate and high risk features. And these patients start to show that the risk of something coming back and shortening a life is significantly higher. And I want you to think about these because as we look at the next slide, I want to emphasize that in comparison to the patients with node positive disease. So most people can be cured with surgery alone. However, if lymph nodes are involved, the prognosis tends to be worse. This is why we check lymph nodes, and often we are using sentinel lymph node biopsy for people because if you have the thin melanoma, but your nodes are positive, it's important. If you have a thicker melanoma and your nodes are positive, it's certainly important because it increases that chance that melanoma will come back and that there can be a worse prognosis. These stages or these lines on the graph here break down the stage 3 patients by stage 3A, B, C, and D, with each one becoming more severe. And that's broken down, or we categorize those by the primary tumor features and the number of lymph nodes involved. When lymph nodes are involved, then the recurrence rates are higher. But why is that? I want you to think about this. When you think about melanoma starting in the skin, if those cells in the skin evolve the ability to travel, survive the trip through the lymphatic vessels into the lymph nodes, then they've already changed. Something has changed in the biology of that cell that allows it to be able to survive and evade the immune system. And in those cases, we know that it may have even gained the ability to spread beyond the lymph nodes. And that's why this is an important detail. So, of all the patients coming into my clinic, about 20 to 25% will have a positive sentinel lymph node. Higher if the tumor characteristics are worse when we start, and lower if they are if they're thinner and without high-risk features. So the last thing I want you to see here, though, is this. This is stage 3A patients, and we've got our arbitrary 80% line here. Stage 3A patients with thin melanomas and a small number of lymph nodes involved honestly tend to do very well without any additional therapy. And this is important because of what the therapies can do. Without that additional therapy, we're looking at 10-year survival of 88%. Most patients do very well. But what about patients with that come in with bulky disease? And this is about 8% of patients that show up in the office with a biopsy on the skin, and we do an exam, and I say, "Oh, I feel something." We do our imaging. We find that what we feel represents melanoma. And what do we do for them? Well, these don't get a sentinel lymph node biopsy. We do complete lymph node dissections. If a tumor has grown in an area like the armpit or the groin or elsewhere, large enough that I can feel it, then it's more likely that it's in more lymph nodes that I might not be able to feel. So additional lymph nodes in that area. And so a complete lymph node dissection is part of my surgical offering to these patients. But how do we decrease the risk? No matter what surgery we do, how do we decrease the risk of recurrent melanoma? Well, we have thought about this historically in a lot of ways, and we used to do more surgery for every patient that had a positive sentinel node. So microscopic evidence of melanoma in a lymph node, we reflexively go back to the OR, take out all of the lymph nodes. And thank God, we had a very large international clinical trial that thousands of patients participated in that showed us that if we go immediately to the OR and do that complete lymph node dissection, or if we wait and do active surveillance, watch very closely to see if anything comes back, and only do that operation if something recurs, we found that the outcomes are not different for those people that have lymph nodes involved. So I don't need to rush back to the OR. In fact, only 20 to 30% of patients will ever need that surgery after that initial positive sentinel lymph node. And 70 to 80% are now spared the more aggressive surgery. So it's a wonderful change in our surgical practice, a de-escalation that matters to patients. So we don't offer more surgery because it doesn't decrease the chance of recurrence in a meaningful way. Radiation. Radiation is not significantly effective for controlling melanoma recurrences. We use it on occasion for more advanced disease when other therapies have been exhausted, but radiation is not a standard. Cytotoxic chemotherapy. So as Dr. Sheng had mentioned, it has a role for advanced disease, but it is not our standard approach, and it does not decrease the chance of any recurrence after surgery. So what do we use? Well, immunotherapy and targeted therapies. Targeted therapies are how I'm going to talk about BRAF and MEK inhibitors that Dr. Schwartz had mentioned. So the standard of care, the standard approach though, that we will offer to most patients is immunotherapy. And this is either a single agent, nivolumab or pembrolizumab after surgery. And how did we get there? Well, this is one of the studies that looks at using pembrolizumab, so Keytruda, after surgery versus a placebo. And what you can see here, this is 7 years of survival where patients that got the pembrolizumab have a higher chance that they're living without melanoma, and that persists. And what it comes down to is the select patients in this trial had about a 15 to 20% fewer recurrences over 7 years, and we expect this to go beyond. So that's important, and it's great. It's great to think about that as is this going to be beneficial for me, and should I be jumping into the therapy? Well, when we look at this graph, and this is the same study, just shortened at 2 years, just for the sake of diagramming, there's a proportion of patients that are not going to respond to our therapy. So even though we give the Keytruda these patients may not respond to it, and they will still have recurrences. There's a proportion of patients that aren't going to have a recurrence regardless of the therapy. And then there's this meaningful 15 to 20% that will actually benefit. So if that's the relative benefit, what about the toxicities? What about the risks? The numbers for this vary in certain clinical trials, but when looking at different reviews that kind of look at the ranges of toxicities, toxicity rates can be about 60 to 70%. Now, most of those toxicities, though, are low grade, manageable, things like fatigue and other things that we can get you through. Serious toxicities are what we think about. These are things that can be life limiting, can require chronic drug management like steroids, or can cause you to come off the drug or the immunotherapy because it can be very harsh. And that happens in about 15 to 20% of people. So when we think about how do we decide, oh, this one got off, sorry. How do we decide who should get it? The severity of the disease matters. So if you're looking at higher stages of stage 3 disease, stage A, B, C, and D, the severity is higher as you go down that line. The relative benefit is greater, though, for each one of these. So if your risk of recurrence is significantly high, then maybe it's worth the benefit of that therapy. Whereas for toxicities, it remains pretty similar across these stages. And so when you are looking at the stage 3A patients, where the relative benefit is small because most patients do well anyway, but the toxicity rates are potentially substantial, then we don't always offer immunotherapy. In fact, when we ask the question who should get it, we tend to let me couch this. Every one of these situations, these patient scenarios, is a discussion between you and your medical oncologist. We may give you all the data that we're talking about here and tell you that we think there's a benefit. But every one of them is a very individualized, shared decision that you need to make with your provider. But we tend to see that the benefit that we can achieve for stage 3B, C, and D often makes sense, especially for the stage 3C and D. Whereas for stage 3A, even though the therapies are approved, the relative benefit versus the risks don't tend to push us in that direction. Now, how about for the early stage, the lymph node negative ones? We don't offer it for patients that have early melanoma. We know most are cured with surgery. For the stage 2B patients, we'll consider it. And then for stage 2C, lymph nodes are negative, but we would still recommend this therapy because these are high-risk primary tumors. So for clinically evident stage 3 melanoma, though, the patients that come in with bulky lymph nodes or other tumors that are resectable, but we know that there's tumor there, we have moved toward a neoadjuvant approach. So Dr. Sheng talked about this. This is very important, and this is very recent that we changed our practice. But because the immune system can be trained against a tumor like this, we know giving the immunotherapy while the tumor is in place is actually better for people. In this picture, we see that the neoadjuvant immunotherapy was given, the tumor shrank, and when I went back and took all these lymph nodes out, there was 0 viable tumor. Even though there was a mass still there, it was all a shell. And that's a wonderful thing, and that gets to Dr. Schwartz's point that at some point, we are going to minimize our surgery even more because we want to minimize the morbidity of what we put patients through. These slides are way off, but this is the graph from the SWOG 1801 clinical trial, where we compared giving pembrolizumab up front for 3 doses and then do surgery and then complete the year of pembrolizumab versus doing surgery and doing the adjuvant therapy, which is our standard of care. And we found that the likelihood of having a recurrence is lower if we do the upfront immunotherapy. So this was a phase 2 trial. And then the more definitive trial that ended up changing our practice for everybody was the Nadina trial. This used Ipi/Nivo, 2 doses up front, surgery, and then looking at, we did surgery for everybody. Looking at the difference in recurrences, it's actually striking. The benefit that we get from this, specifically and especially for people that have a major response to the immunotherapy, is very telling. And what's going to come from this approach is that maybe we don't need to do therapy beyond. If somebody gets a great response from our immunotherapy that we see by taking the tumor out, and we see that there's been a major response, maybe we don't need more immunotherapy. Maybe we can lessen the toxicity of our treatments in that way. Lots will continue, and I think Dr. Mengele will allude to some of that. But here it is. So, do we add immunotherapy for everybody? The answer is no. Who do we tend to consider it for or recommend it for? Well, it's these high-risk patients. And stage 2 patients, even without lymph nodes, can be considered for this. But they have to be the high-risk stage 2 patients. But there are also special circumstances. The stage 3 patients with a larger nodal deposit, greater than 1 millimeter, we weigh the risks and the benefits in that discussion. Then those clinically stage 3 patients, we treat up front. So this is how we approach our consideration for these immunotherapies. And what we are finding is that the harmony that we achieve is decreased recurrence rates. It's hope for better survival. And yet we use it in select patients, understanding that we do not need this for everybody. Melanoma can still be cured with our standard approach for the majority of people with early stage disease. And here's our melanoma disease team. We meet every Monday in our tumor board, and we talk about people with melanoma. We are blessed to have specialists in every discipline, and these conversations get very interesting because we want to make sure that we are offering the standard of care for everybody, that we get it right. And then we're offering clinical trials for anybody that might be appropriate for them. And so these discussions are great. We learn a lot by this practice. And if you are one of the people that we have treated, you have been discussed there. So thank you. Appreciate your time. You need me to introduce you?
Hi, thank you so much, Dr. Rothermel. That was really a very invigorating talk. So last is mine. I take the last piece of the cake, of course. So I'm going to talk about clinical trials, the why, when, and which. I mean, before we start on that, I would again like to say that we are here in Cleveland. We have clinical trials that are expanding all over Cleveland and within the surrounding areas. We have got patients, grateful to patients traveling from as far as New Philadelphia. I honestly had to open Google to see where. New Philadelphia, from Erie, Pennsylvania to as far, is it east? No, it's west. Yeah, west. Finley, Toledo and all those areas. So we are always grateful to patients who participate in trials. Trials help us understand what we are dealing with, and trials help us grow the disease treatment. We are here because 20 years ago, somebody decided to participate in a trial and somebody decided to do that and we could actually advance the treatment. So I always show this photo to my fellows and residents to say, he's the father of clinical, he's often called as the father of clinical trials. He's 17th century British sailor, Navy surgeon, did a trial of oranges on sailors who had scurvy. So 10 people with scurvy, 2 were given oranges and lime juice, 2 were given something else, and 8 didn't improve. 2 people started getting better, reported back to duty within 6 weeks. So he was credited to be the father of clinical trials. So again, like I said, clinical trials are there to expand our horizon of treatment. And even if they don't succeed, they always teach us. They always tell us what to do next, to learn from our mistakes, get up, dust off, and walk forward. And that's why I always say to patients also that without participation of the patients, these are just empty promises. We will never know what clinical trial, what the medicine can do, or what our drug theory, what is our theory. So the why. So I'll address some of the common questions which I get and which I get when I'm talking to patients with clinical trial. And the first question is my insurance going to cover this? It has been one of the biggest projections I've seen in the news, in the media, and everywhere, that somehow clinical trials have been labeled to be a financial burden on the patient. That's not true, because there are always 2 aspects to a clinical trial. No clinical trial will ever be designed, or we will never have a kind of funding where we will be covering for everything. But whatever we do from research perspective, like if there is a drug that is completely new, not approved by the FDA, or we are drawing a blood from you because we want to measure the amount of markers or circulating tumor DNA, which is all research and not approved by the FDA already, that will be paid by the company. That is how we actually go into these contract negotiations for 3 to 4 months with the pharma companies before we actually launch a clinical trial. We are budgeting that, we are making sure that these things are covered and these financial burdens are not translated onto the patients. And then some of the things are standard of care. We will do them regardless. Even if you are not participating in a trial, the fact that you come to the infusion center, the fact that the nurse puts a needle in you and gives you an IV, that is standard of care that we will do for you regardless. So that is what is mandated by national guidelines, by the FDA, and the insurance company should cover that. So that is how all the contracting are made. And then we have an army of back office. Like anytime a patient asks me, will my insurance cover this? I mean, I'm forced to say I'm just a puny doctor. I didn't get a degree in economics, but I have people here in financial counselors who will help you throughout the way. We have an army of social workers, and we'll show you how many people we work with in research trial teams. So the second thing is, am I going to receive a placebo? That was it's almost a thing of the past. There are trials that are still designed with placebos, but they are very, very rare trials. Now, most trials we have an effective therapies in the frontline setting for sure, like the first time we are treating you, and we are trying to improve on them. So they will mostly be in the comparator arm. But having said that, it's all depends on the nature of the disease and what is the availability. If there is a disease, rare disease that has absolutely no treatment approved, or we just have historical data that, okay, this medicine which was approved for some other reason may work in 10% patients, then we would rather, exposing to the toxicity, we may design a placebo-controlled trial. But even in that case, the trial protocol is approved by the FDA. You cannot just willy-nilly start making a trial and launching it out there on patients. But that entirely depends on nature of the disease. And then it's our responsibility to explain to you what is the design of the trial. And that's why there's a process of informed consent. There's a process where we give you consent forms, we talk to you, we sit down with you, and we explain to you the process of trials. Now, FDA is increasingly telling us to design trials where we are blinded. blinding does not mean placebo, which basically means you and I will not know what treatment you are getting. But when we design the trial, we do tell the patient that these are the 2 or 3 arms of the trial, and you will be receiving treatment on each of these arms, which regardless of whichever arm you go on. But it is basically just to measure the quality of life, to measure the patient-related outcomes. We have to blind them so that neither the physician nor the patient knows, so there is no bias in reporting. For example, if somebody is getting an investigational drug, he may be biased in reporting his side effects more compared to somebody who knows that he's getting standard of care treatment. So to eliminate that human bias, nobody does it consciously, but subconsciously it can happen. So eliminate that human bias, blinding is promoted these days, actually. Now, pertaining to randomization, who decides what am I going to get, or why is a computer deciding what am I getting? And that is another question I get, like, why is a human not deciding? Why is it AI? So let me begin by saying AI is not your enemy. AI is trying to help you. And the reason we want the computer to decide. Now, before we say computer, we say there are algorithms which are fed into these AI, into these computers, that are segregating patients equally amongst the arms. They want equal number of men, equal number of women, equal kind of ages, equal kind of tumor burden on each side, so that eventually when the results come out, nobody should come and point a finger that you probably put more older people on one arm, or you probably put people with higher tumor burden on one arm. So that balance and check is created by the algorithm, which is run by AI or computer, and it also eliminates human bias. Trials don't open in one place. They may be international, they may be opening nationally, they may be opening in over 200 different institutions. So if doctors knew that this is the drug which my patient is getting, and they become, and suddenly one doctor starts behaving in a biased manner and starts putting patients onto the arm which has the investigational drug, firstly, it skews the results. We don't know exactly what's going to happen. And then it is not fair to the patients who are participating at other centers. So to eliminate all that bias, you basically gave the job to somebody else who's not a human, who doesn't decide to what kind of patient we are looking at. And then there are genuine concerns which are there from the patients, which number one is that trials are meant for patients who have no options. Why should I do it? Now, this was something which very early on in my career, I was trying to recruit a very young patient onto a clinical trial. And this was a question which took me aback, and I really thought about it. But I think trials are meant for everyone. It is not that people who are failing standard of therapy, only those patients are supposed to go on clinical trials. We actually are trying to get more drugs in the first line setting, getting better drugs in the first line setting, so that we don't have to go to a relapse situation. And we are trying to reduce the toxicity of existing treatment. So in the previous talks, you have heard how ipilimumab and nivolumab is considered to be a higher toxicity but more effective. Can we get something which is less toxic and probably equally effective, or if not more effective? So that question is still out there. We are not 100% in our approach. My dream is that by the time I die, I should have a treatment that I should give only one time. If anybody, I always give this Iron Man reference, which is a little bit crude, but if you look at that he says, which is the best weapon? The weapon you have to fire only once. And that is the reason why we do trials. We do trials where in treatment naive patients who have not seen treatment, because we want to make that one drug which is going to be given to you one time or maybe 2 times, and that is it. Get on back with your life. And so that's why I think trials are meant for everybody. It's not just for people who are not whose melanoma is not responding to the standard care therapy. And then, of course, when somebody talks about a trial, there is always this thought process out there: am I a guinea pig? The people feel they're being experimented upon. I don't think that's true. Firstly, because guinea pigs have no say. Nobody gets a consent form to a guinea pig to sign. And that's not the case. You're not being experimented upon. This is where informed consent and constant monitoring comes into play. FDA watches us like a hawk. If we do not report something on time, we are dinged so much that at times there are times when I go back home and I look at my kid and I see like, when did you grow up? I was just filling out forms of side effects and filling out forms of safety and constant monitoring. The monitoring happens far more frequently on a clinical trial compared to what we do in regular life, because once we have the FDA approval and the regular life starts, we have to deal with the insurance companies, we have to deal with a lot of other factors, and those are all within national guidelines. But trials, of course, are looking for if there is any trouble being caused by the investigation drug. So that's why there is a constant monitoring. And then, of course, there's this factor of your life where patients are working full-time or do have a busy schedule. Let me tell you something, we lay down the red carpet for you when you come on a clinical trial. There is a research team that works with you 24/7. Even on a Saturday, Sunday, you pick up a phone and you call them, they will answer. There is a full team of research nurses, research coordinators, data managers, regulatory team. They're all working with you. We always appreciate your time. We know that this is a time that you're taking out of your regular life. You could have gotten a regular treatment at a cancer center close to you, but participating in a trial, you are contributing a bit of yourself to the humanities, to advancing the disease treatments, and we try to work with you to get you to the best care. We try to squeeze as much as that in one day so that you can get on with your life for the rest of the time. So which trials are good? So this is a phase of drug development, and Dr. Schwartz can talk more about it. But like this is what he does. This is what I have been trying to do. But it starts from the lab. Have a pointer?
Second.
So it starts from the lab over there in discovery where we do the RNA single sequence analysis or even other things. And we find a target and we start designing a drug. And we take it to the mouse, which is basically trying to figure out if it works in a mouse. And then we do a phase 0 trial, which is 10 to 15 patients, very small trial, mostly late stage patients. Then we bring it to phase 1, which talks about, which is finding the safe dose, which we can evaluate in the phase 2 of the trial. And then comes the late clinical stages, which is phase 2, phase 3, where we are comparing the trial either in a smaller group and then in phase 3 in a larger group. And this whole process can take anywhere between 7 to 10 years. And it's a long drawn process, starting right from identifying the target, designing a drug, and then bringing it to phase 3 clinical trial. But I can assure you there will be no drug that has not gone through the whole process before being approved for cancer treatment. There is, even if you look at the earliest approval of immunotherapy in melanoma, which was ipilimumab, it was being designed from 1995 till it got its approval in 2011. It took 16 years for that drug to come through. So it's a long drawn process. There are patients who have helped through the trials, healthy volunteers and patients who have helped through the trial throughout these 17 years and led to the development of the drug. Phase 4 is a post-marketing surveillance. After FDA approval, the FDA keeps looking at the drug, whether it is causing some extra safety signals or not. So then who sponsors the clinical trial? So these are the 3 principal types of trials we do, and there may be more intricacies to how we do this, but these are the 3 principal trials. The first is a consortium-based trials. These are a group of expert oncologists all over the country, all over the US, various cancer institutes, cancer centers. We sit together, we discuss ideas. We discuss ideas and we come up with ideas. We identify problems. We identify like which kind of problems need to be addressed first. And that's how we come to a conclusion. We run these huge trials. consortium-based trials mainly focus on expanding the use of existing drugs. Whatever drugs have been approved by the FDA, we try to mix and match them and try to see which one will lead to a better outcome. Many times it is based on scientific rigor, many times it is based on clinical questions. Pharmaceutical industry now, partners in pharma industry are the ones that are doing the bench research, who are supporting bench research and doing, and they're critical to drug development. Now, the reason pharma has come up in a big way is because they can move fast. They have funding, they have investor funding, so they move fast. That's why if a drug is being found, they can develop the drug much faster. And that process is free of many other issues, and they have good resources. That's why we partner with them, because it is very critical to drug development. And then the last one is the investigator-initiated trials, and these are trials which are initiated by sole physicians, by physicians who are constantly working with the disease and identify a problem, and they can look into certain things and feel like this is an idea they want to try, and they look for. But even investigator-initiated trials will require resources from either the pharmaceutical industry or from the consortiums. So, what is the best for you? So all trials have their own pros and cons. Like consortium-based trials are usually designed around how we will treat the patient in reality, like no extra biomarkers are being looked at. I mean, they do it, but not in a very extensive manner. That's why they can open in multiple institutions, even in satellite institutions, and they have easier accesses. Pharmaceutical trials have a relatively easy access as well, but they are open in areas where the contracts are happening. So that's why it might be a little bit difficult to patients who are far away from the institution to access these trials. And that's why a lot of traveling gets involved. Like I said, most institutions will offer. Investigator-initiated trials are only available at the institutions where the investigator is, or maybe if he's collaborating with 2 or 3 other cancer centers, then the investigator-initiated trial will open over there. Again, consortium-based trials are mostly improving on existing drugs that we already know of. We are mixing and matching. We are trying to make the outcomes better. Pharmaceutical industry is mostly exploring new drugs. And investigator-initiated is a big soft bag. It could be the old drugs, it could be newer drugs mixed with an FDA-approved drug. Again, the funding, like we talked about, they have their own various sources of funding. But what is important about consortium and pharmaceutical trials are because they will change the standard of care. For example, the trial that Dr. Rothermel was alluding to, the S1801 trial and the NADINA trial, basically picked up the standard of care of immunotherapy to be given after surgery, to started giving immunotherapy when the tumor was there, and then taking the patient to surgery, and then eventually giving more immunotherapy afterwards or not, depending on what kind of response we see. Immunotherapy is interesting in that way because the immune system is a very fancy thing to work with. It's once it starts working, once it recognizes the problem, it tends to remember it. It's like taking a vaccine. So when you were a kid, you were given a vaccine for smallpox. That was not smallpox. That was actually cowpox. The earliest development was cowpox, where you used to basically give a small infection of smallpox, which will not hurt you, but it will train your immune system in knowing what smallpox looks like. So whenever the smallpox virus would show up later in life, all your immune system needed to do was to take the book out of that library, open it, and start making the cells that attack smallpox. So you might have contracted smallpox all your life, but you never got affected because your immune system knew how to fight it. We are trying to do that to cancers. Immunotherapy is like that. I always tell people immunotherapy is rooted in this concept that your immune system is not able to see the cancer cell properly. Something is going on which is protecting the cancer cell from the immune system. And we do all these mechanisms which we are deploying are basically trying to help your immune system see the cancer cell. Once it sees it, it will attack it. Our hope is it will attack it, and we'll help it in attacking that. But in the process of attacking, it will create a memory for itself, which we know as the memory T cells. And that will stay with you. That will stay with you for a very long time till the immune system becomes weak again or something different happens. So that's why clinical trials are being done to basically improve on that process. So when to participate? So again, there are different phases of trial. So if you remember the trial the diagram and the flow chart I showed about drug development, there are something called as phase 1 trials. Phase 1 trials are very new molecules, newer concept, newer way to attack cancer. And they are mainly driven by positive data that we have derived from labs. And their goal is to find the maximum dose that can be tolerated in humans, as well as to determine what is the ideal dose to be tested in the larger studies. These trials are not particularly targeting a certain type of cancer. They may be targeting a certain type of cancer depending on what science went on in the lab. But it's it involves two or three different kind of cancers. And our goal is to find the best dose that we can move forward. It's good for patients. Any trial is good for any patient. Let me begin with that. It's not like a certain kind of trial should be done in certain patients. That's not true. All trials are good for all patients, any line of treatment. But it's a very good fit for people in whom the cancer is refractory to the standard care of treatment options. They are very exciting molecules which are being developed in the frontline activity where we are constantly trying to improve on how we treat the disease even in the frontline setting, and those are also in phase 1 trials. Phase 2, phase 3 trials, like I said before, it's a larger study which is either an extension of phase 1 trials or FDA approved drugs with new applications. Their goal is to establish efficacy, which is mainly in phase 2, and to establish superiority, which is in phase 3. So many times, it's not a perfect example, but what I tell people, phase 2 is like running a marathon by yourself. You have a champion, he runs in 3 hours to finish the marathon. In phase 2, you're probably running alone. You finish in 2.5 hours, you are better than the champion. You finish 3.5 hours, you're worse than the champion, but you're running by yourself. Phase 3 is running along with the champion. Now the competition is there in real time. So let us see who does better. So phase 3 is required in many cases for FDA approval, and that's why this whole process is happening. All patients, and it is good for actually all kinds of patients, anybody who has received treatment or has not received treatment. So this is, so at university hospitals, we have been doing melanoma research for almost 4 decades, maybe more than that. But in clinical trial section, there was a brief pause in around 2016-17. And then when we started like our careers, myself, Dr. Rothermel, and then since then we have expanded a lot, and dermatology department has always been there. The research in melanoma at university hospital is expanded quite dramatically. So this is the whole research team. So that's what I was alluding to before, that there is a whole research team. The 5 research specialists who work with you at different institutions, many of you may recognize them. There's research coordinators, there's data managers, regulatory. You probably don't see ever, so I put their pictures also over there, just because you never see them, but they are the people who work for you in the background. And nurse practitioners who are actively seeing patients along with me and Dr. Sheng and Dr. Schwartz, of course. And this is the whole research team where everybody is participating, recruiting patients, offering clinical trials to everybody apart from standard of care. And that's the whole team we have. And in dermatology, we have more dermatologists than I have listed over here, but we also have world-class Mohs surgeons who are doing Mohs surgery for both patients with melanoma and non-melanoma skin cancers. And then we have this awesome nursing team and social work team that work with you to provide you with the comfort of knowing that your every aspect of trials as well as regular care will be covered back. So this is a graph showing how we started and where we are and how's it going. So the one in green basically tells you how many trials we have activated every single year. So we have been activating more and more trials as we go along, and in 2024 we have activated almost 8. And this year alone, it's mid 2025. We have almost activated around 6 trials in melanoma, notwithstanding just the phase 2, phase 3, but also in phase 1. But the blue line shows us the number of patients that have continuously increased as we have gone along. These are the patients who have placed faith in us, faith in the clinical trials, faith in molecules that are being investigated. To me, these are not numbers. To me, these are individuals, these are people who have given their faith to us, and we always respect that faith. So currently, it's just listing the number of clinical trials we have. So we have a surgical study which has been run by an international consortium. I forgot the name of the consortium, but it is run in the US through the Southwest Oncology Group, which is basically looking at if we can resect a smaller amount of skin around the melanoma versus do we have to go with the standard 2 centimeter. Then we have clinical trials in immunotherapy where patients with metastatic disease can enroll onto any one of these trials where EA6141 has been run by a consortium, by the ECOG consortium, which is the Eastern Cooperative Oncology Group, where people are getting either immunotherapy, ipilimumab and nivolumab standard of care therapy with or without a molecule called sargamostim. Sargamostim is a molecule that stimulates a particular group of cells in the bone marrow called monocytes, which help reduce the theory is it will help reduce the amount of side effects but maintain the efficacy of ipilimumab and nivolumab. Then we have a new very exciting molecule in fianlimab, semiplimab, which has been developed by a pharmaceutical company, and we are basically that trial is actively open for patients with stage 4 or unresectable melanoma, which is Regi 1622, and then 1624. Again, the fianlimab, semiplimab has been run against the molecule nivolumab, relatlimab, which is actually the standard of care, not standard of care, which is FDA approved therapy for patients with stage 4 or unresectable melanoma. Then in patients with stage 3, we have trials that are looking at newer molecules after surgery or with patients who have melanoma that can be resected. But now since we do immunotherapy before surgery, we give them these newer immunotherapy regimens, before surgery, and then we take them to surgery. Then we also have the expanded access program with the newer drug called the RP1. I can never say that name, so I call it WUSO. So that's an oncolytic virus. There is one oncolytic virus that has already been approved by the FDA back in 2015, which is called the TVEC or Imiclic, and this is the one which is a newer one. The clinical trial is going on. We offer this oncolytic viral therapy to patients along with nivolumab. And then we have a host of phase 1 clinical trials. I'm just listing the 4 which we are particularly melanoma centric. But we have a whole phase 1 clinical trial program that expands. I think we have actively around 49 trials in phase 1, maybe 51. And we have over 200 patients enrolled who are basically going through for the last 3 years. So these are all newer molecules. We are going to open one of the molecule, which is called the MFI. It's an antibody drug conjugate against CD228, which is antibody drug conjugates are very exciting molecules. They are like homing beacons. So what I explain to people is that there is a protein that is expressed by your cancer cell. Most cancer cells express that protein. Most melanomas express that protein. And we have developed a drug which has a protein that attaches to CD228. The protein by itself will not do anything. But what we did was we attached a small chemotherapy molecule to that protein. So when we put the medicine in the blood and the blood goes everywhere, that protein, that molecule will stick to CD228 and will combine together. And then the cell will think that, oh, it's food, it will eat. But what it doesn't know is that it's also eating the chemotherapy molecule that's attached with it. And that kills the cell. And eventually that chemotherapy molecule will be released into the tumor microenvironment. So any cell that is not consuming, that is not attaching to that protein, will also eventually end up receiving chemotherapy. So this is like delivering chemotherapy at the cellular level, right? So that's we are going to open that that trial very soon. And then there is an interleukin 12 trial which we are already running, and there's a mutation directed trial. So all these phase 1 trials we have here at university hospitals. And of course, I mean, we are always grateful to patients who participate, and we support them as much as we can, and in fact, the best we can. And we are always thankful to all of the patients who have participated. So if you have any questions or concerns, please, these are the phone numbers if you want to take a moment and take a picture. But we are thankful to the AIM at Melanoma Foundation who has sponsored the event and helped us come together. There are people on Zoom also who are listening to this, who are asking questions actively. And we are very grateful to everybody who came together this morning to give their awesome talks. Thank you so much.
It's me first.
Oh, first you. Sorry.
So we have another set of experts here. We have some honored guests that have been diagnosed with melanoma and are here today to share their patient experience with you. And so while they move forward to this table here, I would like to I'm Ann, again, Ann Garst-Taylor with AIM at Melanoma. And I'd like to tell you take just a minute to tell you about our foundation. We are a patient advocacy organization that was founded by Val Gill 21 years ago, after her daughter Charlie was diagnosed with melanoma at the age of 21. There was only one FDA-approved treatment at that time, and unfortunately, Charlie did not respond to that treatment. After she passed away, Val formed AIM at Melanoma with two purposes. One is to find a cure for melanoma. We want to be involved in those things that we think have the closest, the best potential for advancing that lofty goal. The first thing that she did was to form the International Melanoma Working Group. It's a group of researchers that meet by invitation twice a year to collaborate and communicate with one another. Second thing that she did was to begin building 5 tissue banks across the country. We've been collecting tissue for about 8 years now, and we're very close to being able to offer fresh frozen tissue from primary tumors to researchers. And we hope that will advance their research as well. The other thing that AIM is involved in is supporting individuals who have been diagnosed with melanoma. And what form does that come in? Well, it comes in the form of education, because we believe that people who are well-informed make better choices for their care. And I hope that our practitioners today, all of our physicians, would agree that that is true. I want to talk to you about our website where you can get this information. It starts with, by far, the most frequently visited pages have to do with staging and related treatment. In addition, people want to understand what are the potential side effects, and is there side effect management that is possible for that. We have a brand new section that we've just expanded on clinical trials. If you are viewing today on virtually, you will see that I put up a link to that section on our website. We have a service called Talk to a Medical Expert. I know we all have the experience of going into clinic and seeing our physician and walking out and opening up the car door and saying, I forgot to ask my question, right? If you've done that, right? Okay. So Melissa's job isn't to change your plan of care. Her job is to help you to sometimes get some of those questions answered or to understand what the plan of care is. The other thing that she does is those clinical trials that Dr. Mangala was just talking about. She takes on the responsibility of knowing what clinical trials are open, which ones are accepting new participants. And so she sometimes can lead people to clinical trials that they're interested in participating in. She's been working alongside of us for a time now. She is a PA that works with Dr. John Kirkwood at UPMC. And so for about 7 years now, she has been offering this service through AIM at Melanoma. And she said to us, we get many of the same questions. And so she's done a video series called From the Clinic to the Living Room, where she answers some of these same questions and offers those to the public. Like one of the ones that we get a lot is, I've been diagnosed with melanoma, now what? That's by far the most frequently visited video that she's done for us, but it outstrips any of her other videos. So I invite you to come to our website and find some of her webinars. They're excellent. We also do these symposiums. We do 10 a year. They're available to the public either in person, as we have some here today, or virtually. What we do at the end of our symposiums is we take them, we put the entire symposium on YouTube so you can watch it in its entirety and share it with your family. The other thing that we do is we take each of the individual presentations, divide them by topic, and put them back on our website. We have a podcast called Beyond the Clinic. Our host is Dr. Sam Siegel. She is the director of the survivorship program at KP. She herself is a cancer survivor. And what she addresses in our podcast is the emotional impact of being diagnosed with melanoma. The kind of thing that you might not typically talk about in clinic. She wants to talk with you about. We have support for caregivers. We have an entire section just dedicated to those people who are trying to love and support people who are working through a melanoma treatment. And then lastly, we have a peer-to-peer volunteer program, individuals who have completed melanoma treatment and want now to be a source of inspiration and encouragement to people who are just beginning that journey. And so if you are interested either in being a mentor, or if you are finding you're someone who, though you are surrounded by people who love you dearly, you're feeling somewhat isolated and you'd like to add someone to your circle of trust, then get in touch with AIM at Melanoma and we'll be happy to connect you with a mentor. And so to that end, please come to AIM at Melanoma and contact me, and I will be happy to get you connected to any of these resources. All of our resources are available at no cost to the public. Lastly, I'd just like to remind everyone who is in the room today that inside your packet, you have a survey. And those surveys are important to us because as we build additional symposiums throughout the year, your input helps us to make sure that we are presenting the kind of information that's important to you. And so with that, I'm going to pass the baton back to Dr. Mangala and our experts.
Thank you so much. Thank you, everybody. And now we have the people who mattered the most, who did everything that changed the world. And we have a few representatives from that. And this is Mr. David Peterson, Mr. Timothy Gerding, and Ms. Ellen McKenrick. They all participated in the clinical trials, and they're going to give a little bit of your perspective, their perspective on what clinical trials look like, what their melanoma treatment looked like, and how it impacted their life. So let's start with Mr. Peterson.
All right, well, good morning, everybody. So every single thing that you saw on these slides that said the word patient, cross the patient part out and write our names in, okay? Because that's what that really is. So my journey started out, a little bump on my face, went to the dermatologist, he cut it out. I get a call a week later. Has anybody ever taken their car into a shop? And the service guy calls you and says, hey, do you have a minute? You're like, oh man, what's this gonna cost me? You know, here we go. That's the call I got from the dermatologist. Hey, do you have a minute? It's melanoma, right? So what do any of us do? Grab your phone, go to Google, here we go, right? Oh my God, okay, well, I got about 7 months to live, here we go, you know? So anyhow, go up to the UH, we get it cut out. That's when I met Dr. Mangala. And he said, hey, listen, man, you're a blonde-haired, blue-eyed guy. You have a really, really high risk of things coming back. We're going to put you on a more of a preventative type thing, a clinical trial to keep it from coming back. Great. Everything sounds fantastic at this moment, right? So about 2 or 3 months go by. I'm going in, getting these things every 3 weeks. And it was like nothing. No side effects, no nothing. I'm like, man, this cancer stuff is a lot easier than I thought it would be, right? Well, then came a scan. Yeah, it was like December-ish, January, something like that. I'm sorry to tell you, Mr. Peterson, it is metastasized into your lungs. You have 3 tumors in your lung. So then, of course, you whip out the phone, you Google that. Oh, now I'm down to about 2 months, right? Oh boy, here we go. While all this is going on, my daughter, who's sitting right over there, was finishing up her last year in college. And I'm like, okay, my goal, I got to see my daughter graduate. That's what I'm going to live for. That's what I'm going to hang on for. Dr. Mangla, please keep me alive until May so I can watch my daughter graduate. It was all about that, right? And so then, as we discussed in the forms there and in the pamphlets, they took me off one clinical trial and took me on to another one. And my caretakers, my whole team, brought me in. They said, hey, listen, man, here's the way it works on these. Dr. Mangla always has a plan B. And with the clinical trials, just because one doesn't work doesn't mean it's the end of the road. There's always something else, a backup plan or something else that we can try. Bottom line, we're fighting for your life, David. I like it, right? So we go into the next clinical trial. We jump into that. And that was an all-day thing. I would go in about 8 in the morning, and I wouldn't get out of there till about 5 o'clock at night. And those side effects were a little bit brutal, right? A lot of shaking, violent shaking in my body, throwing up, 30, 40 times. I'm not talking 1 or 2 times. I'm talking 25, 30, 40 times at night throwing up, which toughened me up a little bit because when people at work call me and they call in sick, they go, oh man, I threw up, man. I can't make it in. I said, man, you don't even know what throwing up is. You have no clue. Go do what I do for a day and see how that works for you. So anyhow, as time goes on, we're inching closer and closer to May. And I'm like, man, I'm going to make it. I'm going to make my daughter's graduation, right? That was my goal in life. In the meantime, what I did is I prepared to die. So I got my little kit together. I got all my medical powers of attorney. I got the living will and trust. I got every bank account, every electric bill, gas bill, all that stuff, all the accounts, all the PIN numbers, everything set up. So the day that I do go, my 2 daughters could just walk in and it would be a decent transition instead of them scattering around. So I do all this and I prepare to die, right? So now we get into May and I go to her graduation. And that was a great moment in my life. Who wouldn't love to see their daughter graduate from college, right? It's great. So anyhow, she's taking me around to show me her life. And she happens to be a D1 pole vaulter. That was her thing. And she was scholarship through college. I had never thought or heard or felt a pole, for pole vault. And keep in mind, I'm 58 years old. So anyhow, we go up to where she practices pole vault. I said, hey, show me where you practice pole vault. So we go up there and I'm holding her pole, right, to move it over. And her coach happened to drive up. And he said, hey, buddy, you a pole vaulter? I'm like, no. And he goes, well, come on, let me show you a couple things, right? So he shows me a couple things. I'm like, great. So I told my daughter, I said, you know what, as a graduation gift to you, you know what I'm going to do? I'm going to become a pole vaulter. And you know how we're going to do this? We're going to define it as all I have to do to be a pole vaulter is clear 1 jump in 1 meet. And it's on record. And I'm the lowest of the low, but nonetheless, I'm a pole vaulter. So just at this point, the Pan American Games came to Cleveland in 2024. I don't know if any of you heard about that. It was a big thing where people from all over the world, first time the United States has held the event, in Cleveland, of all places, got it. So there we go. So I entered in that, right? So the first event in my age category was high jump. And so we go through all the things in high jump. And I played a lot of basketball and so forth in my day. I'm a pretty decent jumper. And I had never done this before. So we go and all of a sudden people are starting to fall out and contestants starting to fall out. And I'm still in. And all of a sudden we're down to 4. And you have 3 attempts to clear the bar. And this Jamaican guy missed the bar on his 3rd attempt. And I had 1 more attempt. And I said, can you believe this? If I clear this bar, I'm actually going to win a medal, right? In a world competition in high jump. But that's all great and everything, but that's when I had the epiphany of the freedom and the blessing that is cancer. And I know that sounds crazy, but I thought to myself, listen to this. If I don't clear this bar, doesn't matter. I got whatever, stage 3, stage 4 cancer. It doesn't matter. The cool thing is I was here. Think about this. If I clear this bar and I'm wearing that medal, how much greater is the victory than if I was just a regular person, right? You all agree? Yeah, we're not regular people anymore, right? We're like, how cool is it to do this under these circumstances? It makes the victory 10 times as good, and it makes the loss, doesn't matter, who cares? Besides, I had died like 3 months ago, so the death part's already over, so what's it gonna happen, right? So I got that behind me, right, the death part. And that's ultimately the worst thing that can ever happen to you. So I'm like, okay, well, here we go. I clear the bar, I win the medal, right? Told Dr. Mengele, I said, hey man, we got a problem here. He goes, what's that? I said, well, the next time I go in for a TC or a CT scan, whatever, they're gonna have a hard time because I ain't taking this thing off. They're gonna have to work to wear it. So anyhow, we laughed, made a joke about it. So I'm like, man. So that was July. So I turn around and go, I still ain't dead, right? And the tumors in the lung are like shrinking. It's clinical trial. Side effects are bad. But I'm like, man, what's the return on your investment for one bad day of side effects to walk in and have your tumors shrinking? I think that's a pretty good return on investment for the time you spend that day, So that's how I looked at it. And I also looked at it as, listen, my team is trying to help me, but it can't be all them. I got to help myself. I got to stay in shape. I got to lift weights. I got to sweat. I got to run. I got to be ready when I go in there so that they can help me. I'm not just going to, and it reminds me of schools and teaching and so forth. A lot of parents say, oh man, it's the school's job to teach the kids. No, man, it's a group effort, And that's how I looked at this whole thing. So next thing you know, I'm like, okay, this is going to be my purpose. At this point, then winning and getting involved in these sporting events wasn't for me anymore. It's for everybody who's going through what I'm going through with this disease, and everybody in the infusion room getting needles put in their arm, and everybody vomiting and having the shivers and all the side of it. It's for them at this point, right? So I kept at it, and I kept at it, and I kept training, and I kept training. And this summer came around and the Senior Olympics came up. And well, and I'm not bragging or anything, but I did win the gold medal in pole vault. I did win the gold medal. I got a silver medal in the 200 and I won the bronze in the 100 meter. So it's like, okay. And guess what? I ain't stopping because next year is the World Championships in Korea. And I'm going. And I'm going to bring back some hardware. I'm going to dangle it in front of him. And we make a joke. I say, hey, man, can you keep me alive till then? But the way things are going, I think I'm down to what, 1 tumor now, maybe something like that. Whatever it is, it's better than it was a year and a half ago. And when they ask me, hey, your review, what's your yearly review? How do you feel now versus 2 years ago? I say, man, I'm stronger, I'm faster, and I can jump higher. Yep. And my absolute favorite thing, I'll close with this, is whenever I go in, for example, I had to go to Beechwood and get a treatment, and I had never been in there. So a new nurse comes out, and this is my favorite thing. And she's filling out the form, and she said, in the last 3 months, have you fallen? Oh, hell yeah. Yeah, many times. Okay, are you in pain? Every day. Yes. And are you out of breath, short of breath? Every time I run a 200, yes, I'm short of breath. So I always say that. That's just my thing for joking around. But I look at this, and I look at this whole journey as an absolute blessing. I'm a changed man. I'm a better man for this. I'm helping advance the medicine. And I've met some of the most wonderful people I've ever met in my life. That's my
Okay, that's gonna be hard to top. My name's Tim. My journey started in 2019. I was in the garage, I stepped on something on my heel. And I looked at it and I go, well, that's kind of weird looking. The spring comes and it kind of changed. I go to a podiatrist, put my heel up like this, and he's sitting in his chair like this, rubs his chin, he goes, I don't know what that is. I go, that's great, doc. So anyway, he takes a big scoop out of it. He goes, oh, I think that's just that might be a planner's wart or something. I'll send it off to the lab. You're not going to hear from me. Well, I get that phone call from him and he goes, yeah, it's melanoma. So I go and I have 4 surgeries on the heel. Well, 3 surgeries on the heel. They do the sentinel lymph node. They take the lymph node out of the groin. Do all the follow-up and stuff. Then my oncologist, which is not Dr. Mangle at the time, he takes precautionary more lymph nodes out of the groin, which I subsequently find out a couple years later, that's not standard care anymore. But everything's fine. Summer of last year, I start not feeling good, getting pains in my side. Pains all kind of move around. Finally go see my regular doctor, do the blood work. He says your inflammation is through the roof. Anyway, I ended up over at UH when I have a large mass, not even sure, like under the liver. Sign up for the clinical trials, work with Kyle, doing all the paperwork and stuff. And one of the papers you sign is this giant, it's got to be this long of the side effects, right? You got to kind of go through them and 20 signatures. So I go through, start doing the treatment in December of last year. I'm good. It's the IPI and the N word.
Bowman.
So I start doing that. Hey, get the first one, no problem. Oh, this way.
Yeah.
Sorry.
Yep.
Exciting.
So I do the first one, no problem. I do the second one, no problem. The third one, all right, now I'm starting to go check off the list there. Okay. I end up losing 50 pounds. I'm down to 136 at my low point. I remember getting out of the shower, looking in the mirror, and I go, holy mackerel, I can't believe, I told my brother at Christmas, I go, if this doesn't work, I won't be here for Easter. And I can really tell. So the treatments ended up, I'm off the treatment because it affected my liver and some other stuff. But the tumor went from, I'm exaggerating, but went from this to this. And doc says, he goes, I don't know if that's even a viable tumor anymore. I guess you really can't tell. So that's kind of where I'm at. I put the 50 pounds back on. Still having some side effects from the treatment, but from where I was in Christmas of last year, yeah, I didn't think I'd be here. So.
Henrik now, and we also have one more patient, Miss Cindy Jones. She's on Zoom joining us. So Miss Jones will go after. Okay, you go first.
Yeah. So this is phenomenal, the journeys you go on for there you go. Okay. For 38 years, I coached track and cross country. So this is awesome that you do what you do. And I just have to start, thank you so much to the team and for where we're at right now, because without the dedication and I'm amazed at listening to how you all talk and how everything is divided up and what you think, it's amazing. But my journey started in 2013 and I had a stage 2 mole on my neck and they had, we had surgery on it. Before the surgery, they had said they have to inject these most painful shots into my neck. They said it was radiation. It was supposed to highlight whatever was in charge in my neck. The first shot goes in and I'm like, okay, I'm waiting for this pain to hit. And the nurse says, "You okay?" "Sure, I'm fine." The second, third, she goes, "Are you okay?" And I said, "Yeah, is there like a time lapse? We're waiting for this pain," because there was never anything. And she goes, "You should be jumping off this bed screaming." Does the other two, sends me out in the hall. We had to wait like 45 minutes before they did the imagery before we went into the surgery. And so, you know, I look like Frankenstein's bride here because they said everything highlighted, nothing was going the way they went. So they had to search for whatever they were looking for. And when we got done, it healed. They said I was done. There was no need to come in for rechecks or anything. And I says, "Wait a minute, shouldn't I come in like once a year for checks?" And they said, "No." So fast forward 8 years and 21, we went on vacation and I started a cough just before we got there. And I said, "Oh, great, I have a cold, you know, we'll let it run its course." And I'm the type of person, I'm not one that will sit still. And I'm actually, you know, the hauler. We have 6 kids and we pack everything up and I'm hauling. And I said, "You guys go." And they knew something was wrong when I started asking for help. "Hey, will you move that tote over here?" And they said, "You know, you doing okay?" I would have to leave. The cough was so violent, my whole body shook. I didn't have real control over any of it. By the time we left that week, we were stopping in Virginia. I couldn't even lay down flat. I had to be in a 90-degree angle in order to sleep or to breathe. And we left early, came home. Long story, we went into university and they had no clue in the emergency room. The one doctor came in and she says, "Well, we know you have cancer. We don't know what kind, but we're going to set you up with, you know, to see an oncologist." And so 2 weeks later, I met Dr. Mangla. He said, "So what do you know?" I was back up a little bit. I was in the ICU for a week. And then in the Seidman Center for a week after that, they had to drain a cup and a half of fluid from around my heart. And that did help relieve. So I was able to breathe a little bit. And then they sent me home not knowing what kind of cancer it was. They said I had lung cancer, but we weren't sure. So I met him. He sat in his chair. He goes, "So what do you know?" And I go, "Well, I really don't know a whole lot right now. I'm, you know, a little frustrated with it." And I says, the thing I went home with, they said I had lung cancer. It was kind of funny. That was the first part. He goes, "You don't have lung cancer." And I'm like, "Okay, so what do we have?" And he says, "You have melanoma." It engulfed my heart and it was pushing my heart to the right side of my chest. And so we're like, okay, you know, you hear something like that, even in the emergency room, you hear something like that, everybody goes numb. It's like, how do you handle this? And I do remember telling my husband before we were moved into the ICU, I said, "Well, this cancer has picked the wrong body." You know, it sounds a little boastful, but that was all I thought. We're going to beat this right from the get-go. And of course, you know, you continue the prayers, you say, "Help guide me through this, give me the strength." And I truly believe that that's what it was. He sent me in the right direction with the greatest team that I could ever have asked for. I'm here today. We were on I didn't know what was going on. They had never had a case that I was told of in this manner. They didn't know how they were going to treat it, what direction we were going. And then they came up with the immunotherapy, the 4 treatments of both the IPI and the nivolumab. And then after that, they were taking away the IPI. And then I was to do the 2 years finishing up with the nivolumab. But in the meantime, they found that I was qualified for the trial drug. And we had 4.5 doses of it. The trial drug was after the immunotherapy. I would give injections for 14 days at home. And then we'd start it all over again. So after the 4.5, I got called in and they says, "Well, we're going to put you in the hospital for a couple of days." My pancreas had taken a hit, speaking of the list of side effects that it could happen. But, you know, and you look at that and you guys, I waited for side effects when I was on the IPI and the nivolumab. The first treatment, it was fine. I was a little tired for the day, a day or two after that. The second dose, I had some shakes when I got home. The third dose, I had a little shakes in the office, took some Tylenol. And after that, I did not have side effects that, unfortunately, like you guys have experienced, I'm very grateful for that, super grateful. But I was concerned with not taking the trial drug. Is this going to work now? Now am I just not going to survive this? Well, then he started taking, the CT scans we're going through, and it started shrinking. I was concerned. He says, well, it's going to stay in your system for 3 or 4 months. It's still going to work its magic. And I had such severe pain in my back. You could not even touch me. At Christmas time, my son-in-law had gotten my attention from going behind me. He just barely touched my back. It took me to the ground. It hurt so bad. But here, you think back on it, that was the medicine doing its job. It was attacking that big mass in my chest, and it sent, the pain was in my back. Dr. Mangla had sent me for a really long, it was a 6-hour MRI, because he was in fear that it had gone into my bones. And I had to have this MRI taken, and luckily we were told it was not in the bone. Thank goodness for that. And but this miracle was just working, and now today here I am. It has disappeared. There was a few spots left, but we just had CT scans done last week again, and I saw Jessica on Wednesday, and there was a spot on the lung. Everything's gone. It is a miracle. I thank God every day. I thank the team. I thank all you guys for the research you do. This amazing. In 2013, I would have been told, go home, get your affairs in order. You have, X number of weeks or whatever to live. And it is just 8 years later. And now today, in November, it'll be 2 years. I'm done with treatment, and here we are. So it's forever. We'll be grateful.
We have Ms. Jones on the Zoom, and she's speaking from New Philadelphia, the one I had to Google. But she travels every 3 weeks to receive the trial drug. And Ms. Jones, please take it away.
Hello, everyone. Thank you for inviting me, Dr. Mangla. As Anne said, I'd like to say thank you to all of you who have dedicated your career to, I'm an emotional person, to helping us survive. And mine started, I was struggling with bloody noses. I started in February of 2024 with bloody noses, and my nose bled 24/7. When the ENT doctor finally decided to do a CAT scan, he thought what was a polyp in my left nasal cavity, scheduled me for surgery to have that removed. That was in June of last year, 2024. I'm new to the program compared to the other 3 panelists. He removed the tumor, and when I went for my follow-up appointment, gave me the news that I had malignant melanoma. And so that is when he did his due diligence and checked with the 3 major hospitals in Ohio, OSU, Cleveland Clinic, and UH, and said he felt I would be well taken care of at any 3 of those. And fortunately, I picked UH and got in contact with Dr. Mangla. And my first visit was at the main campus. And when the nurse came in, well, Dr. Mangla talked to me about the clinical trial. And I'm like already saying, yeah, I'm in. If I can help other people, I'm in. I'm all in. So, he's like, wait a minute, you have 25 pages you have to read before you agree to this clinical trial. And when his nurse came in to explain it to me, I told her, I said, I know I just met Dr. Mangla, but I have a warm and fuzzy feeling about him. And that's continued, that warm, fuzzy feeling. And I told Dr. Mangla, I said, I walk every day. And I said, I've been telling my body, I've been fighting with the cancer. Get out of my body, get out of my body. I can use the word hate with cancer because I do hate that word. I've had family members, other family members that haven't been so lucky. And he said, don't do that. Cancer likes an audience. They like attention. Just ignore it. So that's what I did. I just went on with my life and ignored it that I had cancer. I was just like everybody else. I'm I'm here. I'm going to do my daily things. I'm going to do whatever I do on a daily basis, and that's what I did. Um, when I started treatment with Dr. Mangla, I told him, and Dr. Mangla, by the way, I'm I'm hurt that you didn't know where New Philadelphia was. So I'm gonna have to like invite you to dinner or something some night. Anyway, I told Dr. Mangla that I was going to be his poster child for this, and I said it's it's not going to get the best of me. So so far I hope I've lived up to that expectation for myself, and so I am in the clinical trial. I went through the first four with both drugs and I'm very fortunate from hearing the gentleman speak. The worst side effect I had was I got a rash from my head to my toes. And that happened on like the second or third treatment. And since then I haven't had any severe side effects. So I feel like I've been very fortunate in that respect. Um, and what Dr. Mangala said about them calling you Saturday, Sunday, any time of the day, it's true because he called me on a Sunday, and my first words out of my mouth is, "Why are you calling me on a Sunday? You're supposed to be resting, and you need to rest because I need you to stay healthy to take care of me." So anyway, I am very fortunate in my treatment. My last CAT scans and MRI, it did travel to my liver. Fortunately, not to my brain or head. So my last set of CAT scans and MRI, which I have every 3 months, showed no signs of cancer. So I'm heading in the right direction. August 8th, I celebrated my first year of immunotherapy, and I have a year to go as long as my body stays healthy to receive the immunotherapy treatment. So again, thank you to all of you who have dedicated your career to finding a cure for this disease. And I can say it and mean it. I love Dr. Mangala and all my team.
Want to say that I'm not promoting myself over. Dr. Sheng is new on board, but she's also helping patients along with us. But no, thank you so much for everyone who has participated today and helped us to understand people, be the voice of people who have participated in clinical trials. There's one voice we cannot listen or hear to right now, but that is of President Jimmy Carter. Somebody asked him if somebody looked back at his history. He was diagnosed with melanoma that went to his brain at 85 years of age, and he was practically given only 6 to 8 weeks to live. But then he went to, I think, Emory, if I'm not wrong, and then he had a surgery, radiation, and then he asked, like, now what? So then the Keytruda was in development at that time, and then somebody came over and said, like, let's give Keytruda. He lived to be 100. And he did not die of melanoma. So that's the hope of immunotherapy, to create that kind of memory in your immune system to keep fighting the cancer, make it into a chronic disease. I always tell people, like, it becomes that pesky neighbor you don't want to talk to. It says there's dying somewhere in the quiet, but he doesn't bother you, you don't bother. Right? But thank you so much for everyone who's participated, please. Do we still have time for Q&A? Yes, we do. So just 15 minutes for Q&A, Dr. Schwartz, if you can join for the Q&A, please. Dr. Beverage. Just a couple of questions, more questions. So. Thank you again for joining us, Dr. Schwartz, Dr. Rothermel, and Dr. Beverage. Dr. Sheng had to go, she's on inpatient service. So there was a question for you, Dr. Rothermel says like, what are the circumstances under which I would probably not be taking neoadjuvant immunotherapy?
So I'm presuming that in this case, the person asking this would come in with something in the lymph nodes that I could feel. If that's not the case for this question, please say so. But you know, if somebody is coming in with a mass and we are going to recognize that the data says you are at a high risk of something coming back, even if we operate. And we know that we are going to be recommending immunotherapy or other systemic therapies afterward. And then we know that the immunotherapy up front is going to be, it's going to give us a higher likelihood that you get a robust response from that treatment. So that is, that's the data, but not every patient can tolerate immunotherapy. Not every patient has the life situation where they can make it to our treatments or be able to navigate going through a year or more of treatment. And so in both of those groups, we have to think, well, what can we do? What can you as a patient do? And what can we do to meet you where you are? And sometimes that is the patient that wouldn't be getting neoadjuvant therapy. But to be clear, just because you can't get neoadjuvant therapy or if you cannot get immunotherapy, doesn't mean that we don't have options. We got options. We just know that some we expect to be better than others, and yet there are always people that surprise us with great outcomes from less. So we're going to aim for it either way.
Oh, thank you. So Dr. Schwartz, this is for you because you've done most research in uveal melanoma. Is there anything to share about treatment for rarer forms of melanoma like uveal melanoma?
Uveal melanoma?
Yes.
I mean, there are new therapies for uveal melanoma. I think they look very promising. It's a different disease with a different activating mutation, but there are systemic therapies now that are quite effective in the advanced disease, and a lot of those therapies are now being used as a preventive approach in the adjuvant therapy. So I think uveal melanoma is different than the cutaneous version for melanoma. I think there's a lot of hope for people with that disease with new therapies that are being developed. Absolutely.
And Dr. Beverage, what does it mean to have a stage 0 melanoma?
Stage 0 is melanoma in situ. So it's just right at that layer of skin where the pigment cells are supposed to be, but they're just more of them. It hasn't invaded, it hasn't started to spread.
And this question is for me. Are there thoughts about addressing inclusion criteria as it may be disproportionate, BMI, hypertension? So we actually take all your history when we put you on a clinical trial, when we are enrolling you on one, we take everything into account. Your BMI, your hypertension, the medicines you take, even the herbs you eat, herbs you take, we ask for that. We want to know what you take because we actually register every single thing, all the diseases you have had in the past, the diseases that you had and never cured of. So some of these things where like we take every single data point and we basically use that and use that to make sure which arm you're going into. So we feed all the data into the algorithm, and then algorithm based on every single thing will decide which arm you go into. So that's I hope I answered that question, but we do take every single data point into effect.
Is that question asking about whether or not the inclusion in trials is going to expand beyond? Is that what it is?
That was me, yep.
Because I think one of the things that Dr. Sheng showed was that there are criteria that if you don't meet this in your health or whatnot, if you have autoimmune diseases, we can't enroll you in the trials. And correct me if I'm wrong, but there are multiple groups looking at trying to expand. There are people that are doing clinical trials specifically for patients with autoimmune disorders and using immunotherapies, not only in melanoma, but immunotherapy birthed out of the research done in melanoma, and it's impacting every cancer now. So there's a lot of reciprocity now. We gain a lot from sharing our experience and then learning from others too. But I do think there are groups looking at expanding the inclusion.
And yes, there was a question about this being recorded. So this is being recorded, and I believe this will be on YouTube forever. So for you, if you want to refer back to it.
Dr. Mangla,
Yeah.
it will be available within about 10 minutes of when we shut down the live stream. That's the melanoma, the symposium as a whole. And then in about 2 weeks, the individual presentations will be available on our website.
Oh, fantastic. And that's the last question of the day. And if there is any other question I did not address today, please feel free to post it on AIM at Melanoma Foundation. We'll work with them to answer all your questions. And this is a question for both Dr. Rothermel and Dr. Schwartz. It's, where do we stand for using circulating tumor DNA to determine recurrence? So Dr. Schwartz.
Yeah, I think it's a valuable tool. I think we can do this now. Those mutations especially are detectable in the blood, the BRAF mutations, the KIT mutations. We do circulating DNA. You can monitor disease for circulating DNA. So it's a tool we use to try to follow and understand the disease. Sometimes, for example, a patient has a recurrence, and rather than biopsying the recurrence to determine do they have a BRAF mutation, you can do a blood test. There are a number of these tests. There's Guardian, there's Natera. And you can find the DNA in the blood. And then you can find the mutation to see if those mutations exist, which reflect the mutations in the tumor. So rather than re-biopsying the tumor, it's always nice to document recurrence, especially if there's a gap. But you can use the blood test now to determine A, is there recurrence? And B, what does that recurrence look like relative to the mutations that are making that cancer grow?
Do you recommend that everybody be doing that?
I think it depends on the situation. So I think in recurrent disease, yeah, I think it should be different too. If you have a metastatic disease, I would recommend it.
And essentially, that I'm asking that question because I get the question a lot. Is there a blood test I should be doing to look for something coming back? And what I showed is that if you starting with an early stage melanoma, then the likelihood of something coming back is already low. And so when you employ these extra tests, there's a lot of anxiety, cost, things that go into that. Now, we need those tests to be great in those settings in order to be very specific, very helpful. And if we can, I think we are still learning exactly who to use it for, but the recurrent and metastatic
early stage disease, I would, but in the advanced metastatic, I'm talking about the metastatic. It's not the early stages. I don't use it. I wouldn't use that in that setting. I do think the anxiety is just exceptional.
Yes, and so this is such a gift because, until very recently, the answer to that question was no, there's absolutely nothing we can do in a blood test. We are advancing and this is going to be very good for us and being able to help you along this journey. So I think it's a great question.
I mean, just to build on that, even this test is going through its own trials to exactly understand the utility of this test as to how and where should we use it and how can we escalate or de-escalate therapy based on what the ctDNA is doing. We still don't completely understand ctDNA, how to use it in a particular setting. We know that we have a technology, but we don't know exactly what is it telling us. So we have to play this down multiple scenarios. And again, this will also go through its own set of trials to basically come up with data points, data sets that help us understand. Now, having said that, there is no therapy that is 100% guarantee. There's never been a therapy that will be 100% guarantee of success. Most of the times we cannot even predict what is going to succeed and what is not going to succeed. And most of the time we cannot even predict that will there be a side effect or will there not be a side effect. So we have to, whatever numbers we give it, we always tell people like this is coming from a group of patients who were treated. And these are the percentages, the medians we tell you, the data we give you, that's not exactly applicable to you. Like we cannot predict what's going to happen to you. But that's what the numbers are. And the numbers are improving as we go along. And that's what trials are doing. It's basically improving those numbers as we go along. But so with that, thank you so much for participating today. Thank you for the Q&A panel. And we're back to Anne. Any closing remarks?
Thank you to everyone who came today. Thank you for all your questions. Thank you so much to Seidman and our wonderful panelists. Can we give them a round?